Okay, let's unpack this. We have a tool in medicine that is absolutely fundamental: oxygen. Simple, essential for life.
Right.
But when we apply pressure, something extraordinary happens. This simple molecule becomes, well, a potent therapeutic agent, effectively a drug with complex physiological behaviors.
Uh,
And for us, as clinicians who use this therapy, the really tricky question emerges. How do we dose hyperbaric oxygen?
that is precisely the central challenge we're diving into today based on the source material.
Okay.
Unlike prescribing a medication with a straightforward dose like milligrams per kilogram.
Yeah, like cephalexin or something.
Exactly. Hyperbaric oxygen doesn't come with that kind of simple, universal label. We're grappling with multiple interacting factors: pressure, duration, frequency, and the actual concentration of oxygen delivered in ways that are often not perfectly understood or scientifically validated or even agreed upon across the field.
Right, and the sources you've shared, particularly highlighting various surveys and reports, they really emphasize this state of clinical equipoise, don't they?
They really do.
That feeling where, as a clinician faced with a patient needing hyperbaric oxygen, you genuinely lack definitive evidence to say, Protocol A is clearly superior to Protocol B for this specific patient and condition. You're in a state of true uncertainty about which option offers the overall best balance of benefit and harm.
Exactly. Clinical equipoise, defined as that state where a clinician genuinely has no basis for choosing between two or more care options, or is truly uncertain about the overall benefit or harm, well, it's pervasive in hyperbaric oxygen therapy protocols.
Hmm.
The data from these surveys makes that abundantly clear. Look at the Hampson and colleagues survey cited. For carbon monoxide poisoning alone, they found practitioners using 18 different protocols across various facilities.
18, just for carbon monoxide poisoning. That level of variation is, well, it's astounding if there was a single proven best approach.
And it's not an isolated finding. That same survey identified 12 distinct protocols being used for mandibular osteoradionecrosis.
12 protocols for mandibular osteoradionecrosis. Wow. It truly highlights the lack of a universally accepted best practice.
The pattern continues. Clark and colleagues reported at least 6 different protocols in use specifically for radiation proctitis.
Okay.
And if you look across multiple systematic reviews on diabetic foot ulcers, they collectively describe at least 6 different foundational protocols being employed.
So 6, 12, 18 different protocols just for the basic pressure and duration settings for a few conditions. And as the source points out, that's before you even consider the frequency of treatments.
Right, like daily, twice daily, 5 times a week.
And the total number of treatments prescribed in a course, which can range from just a few for acute issues to 30, 40, or even more for chronic conditions.
Absolutely.
When you start factoring in frequency and total treatments, the possible combinations of protocols multiply dramatically. You could have a treatment at 2.4 atmospheres absolute for 90 minutes given daily for 30 sessions,
Or maybe 2.0 atmospheres absolute for 120 minutes given 5 times a week for 40 sessions.
Exactly. Those are just two simple examples among potentially hundreds of variations when you look across all conditions and all facilities.
Precisely. And the core problem, as the source clearly articulates, is that despite this huge array of options in use, there is insufficient information available from rigorous comparative studies, particularly head-to-head trials directly comparing different dosages or regimens, to definitively determine a single optimal dose of hyperbaric oxygen for most indications.
So if robust evidence isn't consistently pointing to one superior protocol, how are clinicians making these choices? What's driving the selection of one protocol over another from this vast menu?
Well, the source sheds some light on this. Clinicians often base their choices on existing clinical evidence, perhaps from studies that used a particular pressure and duration that showed positive results. That makes sense.
Sure.
They might also be constrained by the limitations of the specific hyperbaric oxygen equipment available in their facility. Different chambers have different capabilities.
Right, monoplace versus multiplace, pressure limits.
Exactly. Training preferences also play a significant role. You tend to employ the protocols you were taught or are most familiar with.
Naturally.
And, frankly, corporate policies can often dictate standardized protocols across a chain of facilities, aiming for consistency, even if it's not definitively the most effective protocol for every single patient.
That makes sense, too. It's not always about the absolute ideal based on perfect evidence. It's often about what's practical, available, and standardized within a system.
Exactly. The source makes a crucial and perhaps, well, sobering point here. In the end, operational considerations rather than clinical outcomes are more likely to dictate the choice of treatment protocol.
That's a pretty stark statement.
It is. Think about the real-world demands of scheduling patients, ensuring adequate staff availability, managing chamber capacity, and maintenance. These practical factors often hold significant sway in determining which of the many possible protocols actually gets implemented in a facility day to day.
That is powerful. It highlights the significant gap between the theoretical best-case scenario based on clinical data and the practical reality of delivering hyperbaric oxygen therapy in a functioning medical environment. But even if operational factors influence decisions, the source stresses this doesn't negate the need to understand the fundamental components of oxygen dosing.
No, absolutely not.
And that's our mission today, right? To really delve into the details of what constitutes a dose of hyperbaric oxygen, exploring its definition, the factors that determine it, the importance of duration, how we categorize different oxygen environments,
What dose-response evidence exists, or importantly, doesn't exist?
and the complexities surrounding treatment frequency and total treatment length, all grounded firmly in the details provided by this source material.
Absolutely. Our goal in this deep dive is to unpack these specifics and controversies, giving you, the listener and the clinician, a clearer, more granular understanding of the nuances involved in prescribing and delivering this unique therapy and why there's so much variation in practice.
Let's start then at the very beginning, with the basics of defining dose and dosage. The source suggests we try to apply traditional pharmacological constructs.
Right. In standard pharmacology, the dose is typically understood as the measured quantity of a drug given at one time. So if you're prescribing cephalexin, 500 milligrams is a single dose.
Okay, simple enough, straightforward. And dosage.
Dosage refers to the regimen, the regulation or determination of how doses are given over time. So 500 milligrams of cephalexin taken 4 times a day for 7 days, that entire plan is the dosage regimen.
All right, dose is the amount now, dosage is the plan over time. Can we just easily map hyperbaric oxygen onto this framework? Does it fit neatly?
Well, this is where it gets really interesting and, frankly, quite complicated, as the source points out. Applying these precise traditional concepts directly to hyperbaric oxygen isn't straightforward at all. We quickly bump up against fundamental pharmacological questions that, for oxygen, especially under hyperbaric conditions, we often simply lack definitive evidence-based answers for.
What kind of fundamental questions are we talking about, the big ones?
The most basic ones you'd ask about any drug before prescribing it widely. First, is there a clear dose-response relationship for hyperbaric oxygen, where giving more in a specific way leads to a predictably better clinical outcome?
Okay.
And if there is such a relationship, what exactly is the optimal dose for a given condition and patient?
That's a massive question. If we don't know the optimal dose, how can we be confident in picking any protocol?
Exactly. And then there's the question of duration of effect. How long does a single dose or exposure to hyperbaric oxygen actually exert its physiological effects within the body after the treatment session ends?
Right, that duration of effect would directly influence how often we need to give the treatment, wouldn't it?
Precisely. Which leads to the next key question. How often does hyperbaric oxygen have to be given the frequency, daily, twice daily, etc., to maintain a desired effect, drive a healing process, or achieve a clinical response? And finally, for how long, meaning the total number of treatments in a series, does it need to be administered to maximize the likelihood of a positive outcome?
So these are the big unanswered questions that underlie the clinical equipoise and the protocol variation we see. The source highlights that we often just don't have rigorous head-to-head data comparing different approaches to definitively answer these questions across the board. Is that fair to say?
That's the core of the challenge in trying to apply traditional pharmacological principles directly. We have many different protocols, but the foundational understanding of oxygen's kinetics and dynamics in the body, particularly its long-term effects and the optimal cumulative exposure needed for various conditions, is still developing compared to, say, the vast amount of data available for traditional small molecule drugs.
Okay, so the simple definitions of dose and dosage from pharmacology don't neatly capture the complexity of hyperbaric oxygen. We're grappling with fundamental unknowns about dose response, duration of effect, frequency, and total length. That really sets the stage for the complexity we see in clinical practice.
Right. It's a unique therapy that demands a different way of thinking about its administration and effects.
Let's shift gears slightly then and talk about the fundamental physics of determining the dose of oxygen delivered in a single session. The source says it's essentially a product of 2 factors based on Dalton's law of partial pressures.
Yes, Dalton's law is absolutely crucial here. The dose of oxygen, in terms of the driving force for it to move from the lungs into the bloodstream and tissues, is determined by its partial pressure.
Okay.
And that partial pressure is calculated by multiplying the fraction of oxygen in the gas mixture being breathed, what we call the fraction of inspired oxygen, by the total ambient atmospheric pressure surrounding the patient.
So, partial pressure of oxygen equals fraction of inspired oxygen multiplied by the total pressure. That partial pressure is the actual physiological dose being presented to the lungs. Makes sense.
That's the most accurate way to describe the dose of oxygen delivered by the breathing gas. Now, the source does acknowledge, and it's important, that factors within the patient, like underlying lung disease, cardiac function, or the degree of tissue ischemia,
Sure. Patient factors.
they do affect how much of that oxygen actually gets picked up by the blood and delivered to the tissues, its bioavailability. But for the purpose of discussing the delivered dose from the environment following the source, we're focusing on the gas composition and pressure, assuming a normal, healthy patient as the baseline to understand the delivered partial pressure.
Understood. Keep it simple for now. So if we're at constant sea level pressure, that's normobaric conditions, 1 atmosphere absolute, we typically regulate the oxygen dose by simply changing the percentage of oxygen the patient breathes, the fraction of inspired oxygen. Breathing 50% oxygen at sea level, for example.
Correct. The partial pressure of oxygen in that case is 0.5 atmospheres. That's 0.5 fraction of inspired oxygen multiplied by 1.0 atmosphere absolute. However, when you start adjusting the ambient pressure, whether lower than sea level, like at altitude, or higher, like in a hyperbaric chamber,
Right.
describing the dose simply by the percentage of oxygen breathed isn't sufficient or accurate anymore.
Yeah.
You must use the partial pressure of oxygen to truly represent the dose being delivered.
And the source gives a great example illustrating this equivalence in terms of partial pressure. Breathing 50% oxygen at 1 atmosphere absolute gives you a partial pressure of oxygen of 0.5 atmospheres. Simple enough.
But you can achieve that exact same partial pressure of oxygen by breathing 100% oxygen at half an atmosphere, absolute total pressure. So that's 0.5 atmosphere. Absolute total pressure multiplied by 1.0 fraction of inspired oxygen. Still 0.5. Or, and this is directly relevant to hyperbaric therapy, by breathing 25% oxygen at 2 atmospheres, absolute total pressure. That's 0.25 fraction of inspired oxygen multiplied by 2.0 atmospheres, absolute total pressure, which also equals 0.5 atmospheres partial pressure of oxygen.
That concept of equivalent partial pressures is really important then.
It is. It's the fundamental basis for how some sham-controlled trials in hyperbaric oxygen medicine have been designed. The idea is to give the sham or control group a treatment that mimics aspects of the real treatment, perhaps involving pressurization or being in the chamber, but delivers a partial pressure of oxygen that's comparable to breathing room air at sea level, which is about 0.21 atmospheres partial pressure of oxygen.
So trying to isolate the effect of the higher oxygen dose.
Right, aiming for a similar partial pressure of oxygen to normobaric air in the control group. However, the source notes that this methodology may not be adequate, hinting that the physical effects of pressure itself, independent of its effect on oxygen partial pressure, might play a role, which we'll definitely discuss more later.
Okay, that makes sense. From a physiological perspective, partial pressure is key. But in standard clinical practice, when we write an order for hyperbaric oxygen, we usually don't write the prescription in terms of partial pressure of oxygen. We specify the total pressure, like 2.0 atmospheres absolute or 2.4 atmospheres absolute. Why is that the standard way of ordering?
Because most standard hyperbaric oxygen orders inherently assume that 100% oxygen is being delivered to the patient within the chamber.
Ah, the assumption.
Yes. So if you assume a fraction of inspired oxygen of 1.0 per 100% oxygen, then the partial pressure of oxygen delivered is, by definition, simply equal to the total ambient absolute pressure inside the chamber. A prescription for 2.0 atmospheres absolute total pressure implies delivering a 2.0 atmosphere partial pressure of oxygen dose, assuming 100% oxygen.
But the source is quick to point out that this assumption of 100% oxygen delivery isn't perfectly accurate in the real world. What are the practical reasons for that inaccuracy?
The source refers to this as pedantic inaccuracy, but it does have practical implications for the delivered dose. First, medical-grade oxygen itself isn't required to be exactly 100% pure. It's typically certified at 99.5% purity. That's a pretty minor factor, though.
Okay.
More significantly, if you're using a monoplace chamber, which is initially filled with regular air before being pressurized and flushed with oxygen, it takes a substantial amount of time. The source estimates anywhere from 6 to 32 minutes, depending on the system and protocol, to fully displace all that ambient air and get the oxygen concentration up to that near 100% level.
Wow, up to half an hour potentially.
Right. During that initial pressurization or washout period, the patient is not breathing pure oxygen, so the effective fraction of inspired oxygen is less than 1.7.
So the effective fraction of inspired oxygen is below 100% for a portion of the treatment session as the chamber atmosphere is being established.
Exactly. Another factor, particularly in multi-place chambers where patients often breathe oxygen from a mask or a hood, is maintaining a perfect, airtight seal for the entire duration of the treatment.
Which can be challenging.
It can be difficult or even impossible to prevent some degree of air leakage around the mask or hood, which allows ambient chamber air with its 21% oxygen and other gases to be entrained and dilute the pure oxygen the patient is trying to breathe. This effectively drops the fraction of inspired oxygen being delivered to the patient below 100% throughout the treatment session.
So even if you set the chamber pressure to 2.4 atmospheres absolute total pressure, the patient might not actually be receiving a full 2.4 atmospheres partial pressure of oxygen delivered to their lungs for the entire prescribed duration due to these factors like washout time or mask leaks.
Precisely. And the source gives an interesting historical example related to this challenge. Davis, one of the pioneers in hyperbaric oxygen therapy, reportedly used a treatment pressure of 2.4 atmospheres, absolute specifically to ensure that patients received a minimum oxygen dose, which he described as a partial pressure of oxygen of 2.0 atmospheres.
Interesting. So why 2.4 specifically? To guarantee what exactly?
To guarantee that minimum partial pressure of oxygen of 2.0 atmospheres. This suggests that even in those early days, there was an understanding that some margin of total pressure was needed to guarantee a minimum target partial pressure of oxygen dose, accounting for potential real-world dilution or imperfect delivery.
That makes practical sense. You aim a little higher with the total pressure to ensure you hit your minimum physiological dose target, compensating for inevitable imperfections like incomplete washout or mask fit. What about facilities located at altitude? The source brings this up as a crucial factor influencing the calculation of the delivered dose.
This is a critically important practical consideration for any hyperbaric oxygen facility operating significantly above sea level. The total ambient atmospheric pressure is lower at altitude. The source gives the example of a facility situated at 4,000 feet above sea level, where the ambient barometric pressure is approximately 0.864 atmospheres absolute, compared to 1.0 atmosphere absolute at sea level.
Okay, so if the starting ambient pressure is lower, how does that specifically affect the hyperbaric oxygen dose calculation and delivery? This seems like it could get complicated.
It is, and the phrasing in the source regarding altitude is a bit complex, so let's break it down carefully as presented. The source states, a hyperbaric oxygen treatment with a set pressure of 2.0 ATA, 14.7 pounds per square inch gauge, or 33 feet of seawater, would in reality only be delivering a 1.864 atmosphere dose of oxygen.
Okay. How do they get that 1.864 number? If the set pressure is 2.0 ATA absolute, shouldn't the dose be 2.0 ATA partial pressure of oxygen, assuming 100% oxygen?
It's confusing. It seems the source might be calculating this deficit dose. Let's try to parse it. They seem to be taking the intended sea level target total pressure, 2.0 ATA, and subtracting the ambient pressure difference between sea level and the altitude location. So that's 1.0 ATA at sea level minus 0.864 ATA at altitude, which equals 0.136 ATA difference. So 2.0 ATA target minus that 0.136 ATA difference equals 1.864 ATA. It's like they're saying simply reaching 2.0 ATA total pressure at altitude doesn't deliver the same effective dose as 2.0 ATA total pressure at sea level when you account for the lower starting ambient pressure.
Okay, so the source is essentially saying that if your target is a 2.0 ATA partial pressure of oxygen dose, equivalent to 2.0 ATA total pressure at sea level breathing 100% oxygen, simply reaching a total absolute pressure of 2.0 ATA at altitude doesn't quite get you the same dose, at least using this calculation method of compensating for the altitude pressure deficit relative to sea level. That's counterintuitive.
It is. And to actually deliver what they consider a true 2.0 atmosphere dose of oxygen at this altitude, the source then instructs that one would have to increase the gauge pressure by 2.0 pounds per square inch, which is equivalent to an additional 4.49 feet of seawater.
Which is about 0.136 atmospheres.
Absolutely.
Right, that same pressure difference. Exactly. This additional pressure is added to the gauge pressure needed to reach the target absolute pressure. So if your target partial pressure of oxygen dose is 2.0 ATA and your ambient pressure is 0.864 ATA, your total absolute pressure needs to be 2.0 ATA. This normally requires a gauge pressure of 1.136 ATA.
Okay.
The source says to increase the gauge pressure by an additional 0.136 ATA. This would mean your final total absolute pressure becomes 2.0 ATA target dose plus 0.136 ATA altitude correction equals 2.136 ATA total pressure.
Wow. Okay. That is a complex and potentially confusing way to think about altitude adjustments based on the source's description. It seems to suggest that even if you reach the target absolute pressure for your desired partial pressure of oxygen dose, you might need to add more pressure at altitude to truly replicate the physiological effect you get at sea level based on this idea of compensating for the ambient pressure difference. It is confusingly worded, and it highlights the lack of a universally standardized method for adjusting protocols at altitude. And critically, the source explicitly notes that it is unknown whether making these complex adjustments to compensate for altitude using these calculation methods actually results in any change in clinical efficacy.
So we don't even know if this complex adjustment makes a difference clinically.
We don't.
Okay.
So we know how to do the math to theoretically deliver the same partial pressure of oxygen or compensate for altitude pressure loss relative to sea level, but we lack data showing if that theoretical adjustment translates to the same patient outcome.
That introduces yet another layer of complexity and uncertainty in hyperbaric oxygen dosing in the real world.
Indeed. So just to quickly recap the factors determining dose. The core dose of oxygen is the partial pressure, which is a product of total pressure and fraction of inspired oxygen based on Dalton's law.
Right.
While we commonly order based on total pressure, assuming 100% oxygen, that assumption isn't perfectly accurate due to factors like washout time in monoplace chambers and mask fit. Furthermore, real-world factors like operating at altitude require complex pressure adjustments based on potentially ambiguous dosing concepts with unknown impact on clinical outcome.
Okay, that gives us a handle on defining the magnitude of a single dose, but what about the duration of that dose? How long should a single treatment session actually last?
Well, the source indicates that most common hyperbaric oxygen protocols call for the oxygen breathing portion of the treatment to last for between 90 and 120 minutes per session.
Why that specific range, typically 90 to 120 minutes? Is there physiological data to support this duration?
There's definitely data on cellular responses that suggest these durations are relevant. The source references findings from Tom Pash and colleagues. They demonstrated that different cell types involved in tissue repair respond on different timelines when exposed to hyperbaric oxygen.
Okay, like what?
For instance, endothelial cell proliferation, which is absolutely crucial for forming new blood vessels during healing.
Angiogenesis, right.
Yes. That began to show a response after only 15 minutes of hyperbaric oxygen exposure and reached its maximal activity after 60 minutes.
So you can start stimulating new blood vessel growth relatively quickly within the first hour. That's pretty fast.
Yes. However, fibroblast proliferation, which is essential for laying down the structural components of healing tissue like collagen, that required a full 120 minutes of exposure to start showing a measurable response.
That's fascinating. It's like different cellular machinery in the body have different thresholds or activation times when exposed to the hyperbaric oxygen stimulus.
Exactly.
Picture the oxygen washing over the cells, activating different healing pathways sequentially. Endothelial cells gear up for proliferation relatively quickly, but fibroblasts involved in the later stages of tissue building need a longer trigger. This could easily be framed as a board-style question for you as a clinician. Discuss the differential timing of cellular proliferation responses to hyperbaric oxygen for endothelial cells versus fibroblasts based on exposure duration, and explain the potential clinical implications of these different time courses.
Absolutely. That differential response time is a key clinical pearl from the source. The source also describes a study by Hart and colleagues that investigated tissue oxygen tension levels in healthy volunteers during different hyperbaric oxygen protocols. This study gives us a window into how the delivered oxygen dose actually translates into oxygen levels within the tissues themselves over time.
Okay, how was that study designed? What did they compare?
They compared two protocols, both aimed at a total pressure of 2.0 atmospheres absolute. One protocol involved 90 uninterrupted minutes of breathing 100% oxygen.
Simulating a monoplace chamber.
Right, where the ambient gas is oxygen. The other protocol involved 120 minutes of breathing 100% oxygen, but with 5 interspersed 5-minute air breaks.
Simulating a multiplace chamber with mask breathing and air breaks.
Exactly.
Okay, what did they observe regarding tissue oxygen levels in these two scenarios? Any differences?
In the subcutaneous tissue, the uninterrupted 90-minute oxygen protocol achieved a 12% higher peak partial pressure of oxygen compared to the 120-minute protocol that included air breaks.
Okay, that makes sense. The air breaks effectively reduce the cumulative oxygen exposure time within the session.
It does. So continuous oxygen delivery seems more effective at driving oxygen into subcutaneous tissue compared to a protocol with air breaks, even if the total session time is longer in the air break protocol.
What about muscle tissue? Was it the same?
Interestingly, no. Muscle tissue partial pressure of oxygen actually rose more quickly during the initial 20 minutes of the session in the multiplace protocol simulation, the one that included air breaks.
Huh. That seems counterintuitive based on the subcutaneous tissue finding. Why would muscle oxygenation increase faster initially in the air brake simulation?
Well, the source offers a presumed explanation related to the pressurization phase. In the simulated multiplace environment, subjects were breathing oxygen from a mask while the chamber was being pressurized with air.
Ah, getting oxygen right away during compression.
Right. In contrast, in the monoplace simulation, subjects were breathing the ambient chamber atmosphere during pressurization, which was initially air being gradually replaced with oxygen as the chamber was flushed.
I see.
So the multiplace group effectively got a head start on breathing high-concentration oxygen during the initial compression phase, leading to a quicker initial rise in muscle oxygen tension compared to the monoplace group who were still flushing air during compression.
That's a subtle but significant difference based on the chamber type and the oxygen delivery method during the compression phase. It shows how the operational details of the treatment protocol can directly influence the physiological response in different tissue compartments. What specific tissue oxygen levels did they observe, and when were they reached?
They found that subcutaneous tissue partial pressure of oxygen reached a level of 100 millimeters of mercury in both protocols, but approximately 16 minutes of oxygen breathing time.
Okay, relatively quickly to get to 100.
Yes, but reaching significantly higher levels took longer. Subcutaneous tissue partial pressure of oxygen didn't reach 200 millimeters of mercury until 60 minutes of oxygen breathing in the monoplace protocol simulation, and not until 84 minutes in the multiplace protocol simulation with air breaks.
84 minutes. So while a baseline level of tissue oxygenation is reached relatively quickly, driving oxygen levels significantly higher to levels like 200 millimeters of mercury and beyond, levels we think are important for promoting oxygen diffusion distances and influencing cellular functions like combating infection or supporting wound healing.
Right, those therapeutic levels.
That takes a substantial amount of time during the session, and it's affected by those air breaks. Picture the oxygen slowly saturating the tissues layer by layer, with different compartments filling at different rates depending on blood flow and delivery method. This data helps to explain why standard treatment durations are typically 90 to 120 minutes, rather than just a quick 15 or 20 minutes. You need that sustained exposure time to achieve and maintain these higher tissue oxygen levels that are believed to be therapeutically beneficial.
Exactly. And this leads us to a novel concept mentioned in the source for quantifying the total oxygen exposure during a single session, called oxygen hours.
Oxygen hours, how is that defined? What is that?
It's defined simply as the product of the partial pressure of oxygen delivered and the duration of oxygen breathing in hours. So partial pressure of oxygen multiplied by hours.
Okay.
It's an attempt to create a single metric that captures both the intensity and the length of the oxygen exposure within one treatment.
Okay, so it quantifies the total dose per session as a function of both partial pressure and time. The source gives an example calculation. Breathing oxygen and 2.0 atmospheres absolute for 120 minutes, which is 2 hours.
Right, that gives you 4.0 atmosphere hours, 2.0 times 2.
Okay. By comparison, breathing oxygen at a slightly higher pressure, 2.4 atmospheres absolute, for a shorter time, 90 minutes, which is 1.5 hours.
That gives you 3.6 atmosphere hours, 2.4 times 1.5.
Right. This example shows that, by this metric, a protocol using a lower pressure for a longer duration can actually yield a higher calculated oxygen hours dose for that single session compared to a higher pressure protocol with a shorter duration, depending on the specific values chosen.
It does. It's an interesting way to think about quantifying the exposure.
Has this concept of oxygen hours been incorporated into standard clinical protocols or research? Is anyone using this routinely?
The source notes that this concept has not yet been incorporated into standard clinical studies or treatment protocols. So no, not routinely. However, it has been used in at least one analysis of treatment duration, specifically for radiation cystitis, suggesting it's a concept being explored by researchers as a potentially more accurate way to quantify cumulative oxygen exposure per session, even if it's not yet standard clinical practice.
So, to quickly recap Section 3, the duration of a single treatment session, typically 90 to 120 minutes, is supported by data showing different cellular responses like endothelial and fibroblast proliferation occurring on different timelines within that window.
Right, the timing matters.
The heart study illustrated how operational factors like the presence of air brakes, simulating multiplace chambers, versus uninterrupted oxygen, monoplace, significantly affect peak tissue oxygen levels and the kinetics of oxygenation in different compartments like subcutaneous subcutaneous tissue and muscle.
Uh,
And there's an emerging, not yet standardized concept, oxygen hours, attempting to quantify the total oxygen exposure per session by combining pressure and duration.
that covers the definition, determining factors, and duration of a single treatment.
Great. Now let's take a step back and look at how different combinations of pressure and oxygen concentration create a spectrum of oxygen dosing environments. The source provides a verbal description of Table 1, which sounds very helpful here. It illustrates the range of partial pressures of oxygen you can achieve by varying both the total ambient pressure and the fraction of inspired oxygen being breathed.
Indeed, imagine a table. Conceptually, it shows the partial pressures of oxygen can range from the 0.21 atmospheres you get breathing room air at sea level,
Right, 1 atmosphere absolute total pressure times 0.21 fraction of inspired oxygen.
all the way up to potentially 3.0 atmospheres,
Yeah.
or even higher, depending on the pressure and oxygen concentration used. The table makes it clear that partial pressures up to 1.0 atmosphere can be achieved at sea level simply by increasing the fraction of inspired oxygen up to 100%. But to achieve a partial pressure of oxygen greater than 1.0 atmosphere, you absolutely must be in a hyperbaric environment, that is, at a total ambient pressure greater than 1 atmosphere absolute.
Correct. No way around that. And the source uses this continuum of possible partial pressures and pressure-oxygen combinations to delineate 4 main categories of oxygen dosing environments for discussion: normobaric hyperoxia, hyperbaric normoxia, hyperbaric hyperoxia, and the traditional definition of hyperbaric oxygen.
Let's start with normobaric hyperoxia. What is that exactly?
This is defined as breathing increased amounts of oxygen, meaning a fraction of inspired oxygen greater than the 0.21 found in room air while remaining at sea level pressure, 1 atmosphere absolute.
Yes, it's breathing anywhere from, say, 25% oxygen up to 100% oxygen while staying at standard atmospheric pressure.
Yeah.
Within this normobaric range, you can achieve partial pressures of oxygen from 0.21 atmospheres up to a maximum of 1.0 atmosphere. And even within this normobaric hyperoxic range, the source notes several clinically relevant effects. For instance, the elimination of carbon monoxide from the body is directly related to the oxygen concentration breathed at normobaric pressure.
Higher oxygen, faster carbon monoxide washout.
Exactly. Similarly, nitrogen elimination during treatment of decompression sickness is also dependent on the oxygen concentration.
So simply increasing the percentage of oxygen breathed at sea level can be a powerful therapeutic tool for conditions involving gas exchange issues. Makes sense.
Absolutely. There are also some less intuitive physiological effects mentioned. For example, erythropoietin production, that hormone that stimulates red blood cell production.
EPO, yeah.
It's stimulated by intermittent administration of normobaric oxygen. However, it's unexpectedly depressed following hyperbaric oxygen exposure.
Wow, that's a fascinating contrast. The same molecule oxygen can have opposite effects on erythropoietin depending on whether it's delivered at normobaric or hyperbaric pressures.
It really highlights the complexity of biological responses to different oxygen environments.
That is one of those surprising facts that makes you realize it's not just a simple linear effect of oxygen. Why the different effect on erythropoietin, that raises a significant question about the underlying mechanisms.
It does, and while the source notes the finding, it doesn't delve deeply into the specific mechanisms for this difference. But it clearly points to complex biological responses beyond just increasing tissue oxygen levels.
Okay.
Another finding mentioned is that normobaric oxygen has been shown in an animal model to increase circulating stem progenitor cells.
Really? Just normobaric oxygen?
Yes. The source notes that this effect mimics some of the effects seen with hyperbaric oxygen, raising a fundamental question. How much pressure is truly necessary to elicit some of these beneficial cellular responses versus how much is simply due to the increased partial pressure of oxygen itself, which can also be achieved at normobaric pressure by increasing the fraction of inspired oxygen?
So some of the benefits we often associate with hyperbaric oxygen might in fact be achievable with just high concentration oxygen at normobaric pressure for certain specific effects. Like stem cell mobilization, maybe?
Potentially, for effects like stem cell mobilization. The source also mentions the production of reactive oxygen species.
Ah, ROS.
Yes, those highly reactive molecules often associated with oxidative stress and signaling pathways. Their production increases even at normobaric pressures as you increase the fraction of inspired oxygen. This increase was shown at 10%, 15%, 30%, and 100% oxygen at 1 atmosphere absolute.
So increased oxidative stress response isn't exclusive to hyperbaric conditions. It starts increasing even at normobaric levels with higher oxygen concentrations.
Exactly. This indicates that the cellular stress response begins well before hyperbaric pressures are reached.
So a key takeaway here is that even low levels of increased oxygen, well within the normobaric range, can elicit very significant cellular responses. This challenges any simplistic notion that you need massive hyperbaric pressures for any physiological effect.
Absolutely. And the timing of those responses can differ significantly depending on the oxygen environment. The source gives the compelling example of hypoxia-inducible factor 1 alpha, or HIF-1 alpha.
HIF-1 alpha, right, the master regulator in low oxygen.
Yes, this is a crucial transcription factor that, under conditions of low oxygen, hypoxia, becomes stabilized and activates genes needed for survival and adaptation, such as those that promote angiogenesis or produce growth factors.
So under normal oxygen conditions, HIF-1 alpha is quickly broken down, but under low oxygen, it's stabilized to help cells survive and adapt.
Exactly. Now, here's the fascinating difference in timing highlighted by the source. With normobaric oxygen, specifically breathing 30% oxygen for 1 hour, HIF-1 alpha expression shows a very strong and quick increase. It remains elevated even after 3 hours post-exposure.
So a rapid, strong response with normobaric hyperoxia, very fast on.
Compare that to the response with hyperbaric oxygen exposure. The increase in HI-1 alpha is slower initially, but critically the effect lasts for 24 hours.
24 hours. That is a fundamental difference in the kinetics of the response. Picture HIF-1 alpha as a molecular switch that activates the cell's repair and adaptation programs. Normobaric oxygen might flip that switch hard and fast, but the signal might fade relatively quickly.
Right.
Hyperbaric oxygen, however, seems to flip the switch more slowly, but it keeps that signal active for a much, much longer duration. This suggests that different pathways or mechanisms are engaged or regulated differently by the hyperbaric stimulus compared to just normobaric hyperoxia, even for something as fundamental as HIF stabilization.
It's a key piece of the puzzle in understanding why daily hyperbaric oxygen treatments, despite the long intervals between sessions, might be sufficient to drive clinical responses, as we'll explore later. That sustained effect on key molecular pathways is significant.
Okay, that's normobaric hyperoxia. Very interesting effects even there. What's the next category of oxygen environment discussed?
Hyperbaric normoxia. This is defined as breathing a gas mixture with a fraction of inspired oxygen of 0.21 essentially, standard room air, but at a total ambient pressure greater than 1 atmosphere absolute.
Okay.
In practical terms, this means breathing hyperbaric air.
Hyperbaric air. The source mentions this has a historical context in the field.
Yes, it was used by early pioneers like Henshaw and Fontaine even before oxygen was identified as a therapeutic gas. They observed benefits simply from placing patients under increased pressure. However, the source notes quite directly that its use historically was often without any evidence to support its use.
So not much science behind it initially.
Right. There's a legacy here where hyperbaric air was applied based on empirical observation rather than clear scientific evidence, and that lack of a strong evidence base has persisted.
And the source refers us back to the verbal description of Table 1 again when discussing this category. Why?
Sure. Right. If you look at the partial pressure of oxygen levels you can achieve by breathing 21% oxygen, fraction of inspired oxygen 0.21, at pressures greater than 1 atmosphere. Absolute, say, at 1.5 atmospheres, absolute total pressure, or 2.0 atmospheres, absolute total pressure, you can see the resulting partial pressure of oxygen.
So at 2.0 atmospheres, absolute total pressure breathing air. That's 0.21 times 2.0, 0.42 atmospheres partial pressure of oxygen.
Exactly. If you then compare that to breathing higher percentages of oxygen at normobaric pressure shown in Table 1, you'll notice there's a tremendous overlap in the achievable partial pressure of oxygen levels between breathing hyperbaric air at different pressures and breathing less than 100% oxygen in a hyperbaric environment, which is the next category we'll discuss.
So breathing hyperbaric air at 2 atmospheres, absolute total pressure delivers a partial pressure of oxygen of 0.42 atmospheres absolute, which is physiologically equivalent to breathing about 40% to 50% oxygen at sea level, around 0.4 to 0.5 atmospheres absolute partial pressure of oxygen.
Exactly. And this leads to a critical, fundamental, and still largely unanswered question highlighted by the source. Is there any clinical or physiological difference between raising the partial pressure of oxygen in the body by increasing the total ambient pressure while breathing air, hyperbaric air, versus raising the partial pressure of oxygen by simply increasing the fraction of inspired oxygen breathed at 1 atmosphere, absolute, normobaric hyperoxia?
Is it the total pressure that matters, or just the resulting partial pressure of oxygen presented to the lungs? Or both.
Precisely. Is the increased pressure itself, independent of its primary effect on oxygen partial pressure, contributing a unique physiological effect? And the source suggests that studying the effects of micropressure, very small increases in pressure, less than 20 kilopascals or zero point 0.2 atmospheres over atmospheric pressure on cellular activity, is one avenue researchers are pursuing to try and isolate and understand if pressure itself, independent of how it affects oxygen partial pressure, has a direct biological effect.
But the mechanism isn't confirmed?
Not confirmed, no. It's still a hypothesis.
Fascinating. It seems like the boundaries between these categories are physiologically blurry when you just look at partial pressure of oxygen. Okay, moving on. The third category is hyperbaric, hyperoxia.
This is a broad category encompassing clinical studies and practices that use a gas mixture with a fraction of inspired oxygen, less than 100%, but at a total ambient pressure greater than 1 atmosphere absolute.
So this would include, for example, protocols breathing 24% oxygen at 1.3 atmospheres absolute, or maybe 40% oxygen at 1.5 atmospheres absolute. Things like that.
Yes, exactly. And precisely because this category involves varying both the total pressure and the fraction of inspired oxygen, often aiming for a specific target partial pressure of oxygen, it's inherently difficult, as the source notes, to definitively determine whether any observed clinical effects are solely attributable to the hyperoxia, the increased partial pressure of oxygen, or if the hyperbaria, the increased pressure itself, is also playing a significant, perhaps synergistic role.
Which brings us back to that core question we just discussed regarding hyperbaric normoxia. Is it the pressure or the oxygen partial pressure? And the source points out that many of the indications or conditions often treated within this category involve some form of brain injury.
Yes, conditions such as autism, cerebral palsy, and traumatic brain injury. And for these specific indications, the source states, with perhaps a touch of clinical understatement, that the division of opinion on the benefits of hyperbaric oxygen, particularly administered in this hyperbaric hyperoxia range, is significant.
Significant division. Okay, let's look at some of the study examples the source provides that contribute to this controversy. Rossignol and colleagues, in a study on autism, found that breathing 24% oxygen at 1.3 atmospheres. Absolute total pressure resulted in superior outcomes compared to breathing 21% oxygen at 1.03 atmospheres. Absolute total pressure.
Right. But the source immediately highlights the challenge in interpreting this finding in terms of isolating the pressure effect from the oxygen effect. Breathing 24% oxygen at 1.3 atmospheres,
Yeah.
absolute total pressure delivers a partial pressure of oxygen of approximately 0.312 atmospheres.
Okay.
Breathing 21% oxygen at 1.03 atmospheres.
Yeah.
Absolute total pressure delivers a partial pressure of oxygen of approximately 0.216 atmospheres.
So comparing about 0.3 ATA partial pressure of oxygen to about 0.2 ATA partial pressure of oxygen.
Essentially, yes. And critically, the source points out that a partial pressure of oxygen of 0.3 atmospheres can easily be delivered without needing any hyperbaric pressure at all, simply by breathing about 30% oxygen at 1 atmosphere. Absolute total pressure.
Good point.
This again raises the question, was the benefit seen in the Rossignol study primarily due to the increased partial pressure of oxygen, or was the increased pressure even just to 1.3 atmospheres? Absolute, also a necessary component.
It's hard to separate the variables. What about other studies on brain injury? The source mentions another randomized controlled trial on autism that compared breathing 100% oxygen at 1.5 atmospheres. Absolute total pressure.
Delivering a partial pressure of oxygen around 1.5 atmospheres absolute.
Versus breathing 21% oxygen at 1.15 atmospheres, absolute total pressure.
Delivering a partial pressure of oxygen around 0.24 atmospheres absolute.
Yeah.
So a bigger difference in oxygen dose there.
Yes. What happened in that trial?
In that specific study, both groups showed significant improvement from their baseline measurements before the study began.
Both improved. Okay.
However, there was no statistically significant difference between the groups in terms of the degree of improvement. The group receiving the higher pressure hyperbaric oxygen wasn't demonstrably better than the group breathing near normobaric air at slightly elevated pressure.
And the source notes that this specific phenomenon where both the active treatment group and the sham or control group shows significant improvement from baseline, but there's no statistical difference when comparing the two groups directly. This has also been observed in studies investigating hyperbaric oxygen for cerebral palsy and for traumatic brain injury.
Yes, this pattern of results in multiple studies fuels the significant controversy in this area. Skeptics interpret these findings and conclude that the improvement observed in both the active and control groups is primarily a placebo effect, driven by the intensive nature of the treatment and the hope it provides.
So they'd say it's not the hyperbaric oxygen itself.
From this perspective, they would conclude that the question is effectively answered. Hyperbaric oxygen is not specifically effective for these conditions, and the observed improvement is nonspecific.
But others in the field strongly disagree with that interpretation.
They do. Proponents argue that the sham protocols used in these studies, which typically involve breathing 21% oxygen at a minimally elevated atmospheric pressure like 1.03 or 1.15 atmospheres, absolute, are not inert or inactive.
The sham isn't really a sham.
They contend that these low-pressure normal oxygen protocols do generate their own measurable physiological effects, perhaps through the proposed micropressure mechanism we mentioned,
Right.
and therefore should not be considered a valid control group if the goal is to isolate the effect of higher pressure oxygen.
So the debate becomes, was the minimal pressure in the sham group sufficient to cause some beneficial effect, thereby masking any potential difference compared to the higher pressure group? Is that the argument?
Exactly. It brings that micropressure hypothesis back to the forefront. The source notes the theory that micropressure itself, again, less than 20 kilopascals or zero point 0.2 atmospheres over atmospheric pressure, may exert a positive clinical outcome. Although, as mentioned, the precise mechanism for this theoretical effect is not confirmed.
It's a complex web of conflicting data and interpretations. Are there any studies mentioned that contradict this pattern of sham improvement? Any counter evidence?
Yes, the source does contrast some of these studies with others on traumatic brain injury. For instance, the BIMA randomized controlled trial found that 1.5 atmospheres absolute oxygen was superior to 1.2 atmospheres absolute air, which delivers about 0.25 atmospheres absolute partial pressure of oxygen, specifically at the 13-week follow-up mark post-injury.
Okay, a short-term difference.
Although that difference was not sustained when patients were assessed again at 12 months.
Okay, so some evidence of a short-term difference there. What about the HYBOB2 study? That sounds relevant.
The HYBOB2 double-blind randomized controlled trial investigated the effects of 40 treatments of hyperbaric oxygen at 1.5 atmospheres, absolute delivering around 1.5 atmospheres, absolute partial pressure of oxygen for non-stroke traumatic brain injury. They compared this to a sham group that breathed air at a very low micropressure, just 0 0.1 pounds per square inch gauge, which is only about 0.00068 atmospheres above ambient pressure. Very low.
Tiny pressure difference, and the result.
In the specific study, the hyperbaric oxygen group did show improvement on the neurobehavioral symptom inventory compared to the sham group, and importantly, no benefit was observed with that very low micropressure air-breathing sham.
So the HYBOB2 study seems to provide evidence supporting the idea that the higher pressure oxygen is effective for this specific outcome, and that a very low micropressure sham doesn't produce a clinically meaningful effect in this context.
It seems to, yes.
But the other brain injury studies still show that puzzling pattern where minimal pressure shams do seem to show improvement, sometimes equal to the active group.
It remains a complex and somewhat contradictory body of evidence, particularly when trying to interpret the results for these brain injury indications and understand the role of pressure versus oxygen partial pressure. And the practical reality on the ground, as the source describes, is that despite this controversy, many patients are receiving oxygen in facilities using pressures in this hyperbaric hyperoxia range, typically 1.3 atmospheres absolute or lower, often breathing mixtures of 21% to 40% oxygen.
And the source points out that many of these facilities promote their services by advertising that they provide hyperbaric oxygen.
Yes, and this can lead to confusion for the lay public, who might assume that this is the exact same therapy as the hyperbaric oxygen traditionally delivered in a hospital setting, which has typically involved pressures of 2.0 to 2.5 atmospheres absolute with near 100% oxygen.
Right.
This creates potential marketing confusion and can make it difficult for patients to understand exactly what treatment they are receiving and what evidence supports it.
It does seem like the very definition of hyperbaric oxygen has become somewhat blurred in common usage compared to the more stringent definition often used in traditional medical settings and evidence reviews. The source mentions a historical definition that set a pressure limit of 1.4 atmospheres absolute to be considered hyperbaric.
That historical definition was actually scientifically inaccurate, as the source clarifies. By strict definition, any pressure greater than 1.0 atmosphere absolute is hyperbaric.
Okay.
As the verbal description of Table 1 illustrates, there is a wide continuum of what could technically constitute hyperbaric oxygen based on combining varying pressures and oxygen concentrations to achieve different partial pressures of oxygen.
But the source emphasizes that while the technical definition is broad and there's this continuum of possibilities, the greatest body of evidence to support the clinical use of hyperbaric oxygen for established indications exists for pressures administered at 2.0 atmospheres absolute and higher.
That's a critical point for clinicians who are making decisions based on the existing evidence base. Decisions should ideally be guided by where the most robust data lies, even if the theoretical possibilities for dosing span a much wider range across this continuum.
Makes sense. Stick with the stronger evidence.
The source adds that as new research emerges, particularly from studies in the hyperbaric hyperoxia category, new indications might eventually be added to clinical practice, but they should ideally be evaluated through the same rigorous evidence-based process.
Okay, so we've covered normobaric hyperoxia, hyperbaric normoxia, hyperbaric air, and hyperbaric hyperoxia with its associated controversies, particularly regarding brain injury indications. What's the final category discussed? The main one.
Hyperbaric oxygen, specifically as it's traditionally understood and as it's extensively discussed in the manual from which this source is taken. This category is defined by the delivery of near 100% oxygen at pressures typically greater than 2.0 atmospheres absolute.
And why use the phrase near 100% rather than simply 100% oxygen, just purity standards?
The source explains that this phrase exists primarily because, historically, suppliers of medical-grade oxygen couldn't guarantee precisely 100% purity. It was typically certified at 99.5%. While a minor distinction, this raises the perhaps pedantic but relevant question: if a facility uses 95% oxygen, does that technically still count as hyperbaric oxygen in this traditional sense?
It shows how practical limitations can influence the very terminology we use. And speaking of practicalities, the source reiterates the risk of underdosing even when attempting to deliver pure oxygen.
Yes. Whether you're using a mask or a hood for oxygen delivery to the patient inside a multi-place chamber, there's a constant risk of air leaks from a poorly fitting mask or incomplete displacement of the ambient chamber air if you're using a hood without sufficient purging.
Right, those leaks again.
These issues effectively dilute the oxygen the patient is breathing, lowering the effective fraction of inspired oxygen they're receiving below the intended near 100%.
So even with pure medical oxygen supplied to the chamber or mask, you might not consistently achieve a true near 100% fraction of inspired oxygen at the patient's airway interface throughout the entire session due to these real-world factors.
Exactly. And this is why the source argues that from a practical standpoint, it makes the most sense to start from the highest possible dose of oxygen purity by using the purest form of medical oxygen available to build in a margin and account for any potential decrease in delivered concentration due to these real-world challenges like leaks or incomplete washout, particularly in monoplace chambers during compression.
Physiologically, though, as we discussed earlier regarding the partial pressure calculation, you could theoretically reach the same target partial pressure of oxygen using different combinations of oxygen concentration and total pressure. For example, breathing 50% oxygen at 4 atmospheres, absolute total pressure would yield the same partial pressure of oxygen as breathing 100% oxygen at 2 atmospheres. Absolute total pressure.
True. Physiologically, the partial pressure of oxygen is the key driver for gas exchange. But the source notes that in standard clinical practice, we don't commonly customize our delivery to a specific target partial pressure of oxygen by complex adjustments of both fraction of inspired oxygen and total pressure.
It's just not done routinely?
No. Standard practice generally defaults to using near 100% oxygen and then simply specifying the target total pressure, assuming the resulting partial pressure is equivalent.
And is there any potential physiological significance to using less than pure oxygen? Does it matter if there's nitrogen or other gases? The source mentioned some have argued this point.
Yes, the argument raised by some is that using anything less than pure oxygen introduces a higher partial pressure of the other gases present in the breathing mixture, such as nitrogen or argon. Some have argued that these increased partial pressures of inert gases may have their own measurable physiological effects, although this is also a point of debate and further research.
Another potential layer of complexity in understanding the true biological effects. Always more questions.
Indeed. But drawing this section together, the source's suggested best definition of hyperbaric oxygen, particularly in the context of the manual and the evidence base, is one where the purest form of oxygen available is delivered to the patient.
Okay, wow. That was a thorough exploration of how different combinations of pressure and oxygen concentration create this spectrum of dosing environments. Let's quickly recap Section 4.
Absolutely. We broke down the 4 main categories of oxygen dosing environments: normobaric hyperoxia, where increased oxygen is breathed at sea level.
Right, and we talked about effects like carbon monoxide and nitrogen elimination, the weird EPO response, stem cells, ROS, and that different HIF timing.
Exactly. Then we covered hyperbaric normoxia, or breathing hyperbaric air, noting its historical use without clear evidence, and raising the question of whether increasing pressure while breathing air has different effects than increasing oxygen percentage at sea level, given the significant overlap in achievable partial pressure of oxygen illustrated by the verbal description of Table 1. Next was the broad category of hyperbaric hyperoxia, using less than 100% oxygen at pressures above 1 atmosphere absolute, often applied to brain injury indications.
And all the controversies there, the conflicting studies, the sham debate, micropressure theory, marketing confusion.
Right. And finally, we discussed hyperbaric oxygen in the traditional sense, defined by the delivery of near 100% oxygen, acknowledging the real-world challenges of achieving perfect purity and mitigating underdosing risks from factors like washout time or mask leaks. We emphasized that while technically there's a continuum of possibilities, the strongest body of clinical evidence supports the use of hyperbaric oxygen at pressures of 2.0 atmospheres absolute and higher.
It's clear that classifying and comparing these different environments is complex, with significant overlaps in achievable partial pressure of oxygen according to Table 1, and ongoing fundamental questions about whether it's solely the increased oxygen partial pressure, the physical effects of the increased pressure itself, or a specific combination that drives the clinical effects for different conditions.
All right, let's tackle the big question we raised at the beginning. Is there a clear dose response to oxygen in terms of clinical outcome? We've seen there's a spectrum of environments and that even low-level normobaric hyperoxia has effects. But does more oxygen or higher pressure lead to a predictably better clinical outcome across different conditions?
Where do we start looking for that answer? Cellular level.
We can start by looking at the cellular level, where the evidence for a dose-response relationship appears much stronger than at the clinical level. The source references the comprehensive review by DeWolde and colleagues, which showed that hyperbaric oxygen has both stimulating and inhibitory effects on cellular processes like oxidative stress, inflammation, and angiogenesis.
Okay.
And that these effects can vary depending on whether you're looking at the impact of short courses, 1 to 3 treatments, versus longer courses, 20 to 30 treatments.
So even at the cellular level, the response depends not just on a single dose, but potentially on the cumulative exposure over multiple sessions. That makes sense.
Yes, that review suggests cumulative effects are important. And other studies provide specific examples of a clear dose response at the cellular level related to the intensity of the dose. Hyperbaric oxygen significantly increases the proliferation rates of various cell types crucial for tissue repair.
Like epithelial cells, endothelial cells, fibroblasts.
Exactly, compared to just normobaric oxygen. While the source doesn't explicitly provide a dose-response curve for proliferation within the hyperbaric range, the fundamental comparison to normobaric oxygen implies that increasing the partial pressure of oxygen into the hyperbaric range provides a greater stimulus.
What about effects on inflammatory markers? Anything there?
Yes, hyperbaric oxygen has been shown to suppress the expression of intercellular adhesion molecule, or ICAM, by activated neutrophils.
ICAM suppression. Okay. Why is that important clinically?
Well, suppressing neutrophil adhesion is clinically relevant because it can reduce the excessive accumulation of inflammatory cells at sites of injury, potentially mitigating tissue damage and promoting healing, especially in conditions involving reperfusion injury, where initial ischemia is followed by blood flow restoration. This is a clear mechanism linking oxygen dose to an anti-inflammatory effect. The source notes this effect is observed at oxygen partial pressures of 1.0 or 2.0 atmospheres, targeting a tissue partial pressure of oxygen greater than 20 millimeters of mercury.
That's compelling cellular evidence. What about stem cells? We mentioned those earlier.
Stem cell mobilization shows a clear dose response based on the total number of treatments. The source highlights that a single hyperbaric oxygen treatment increases circulating stem cells by approximately 2-fold.
Okay, twofold after one.
But critically, after a series of 20 treatments, that mobilization increases dramatically to an 8-fold increase compared to baseline.
Wow, an 8-fold increase after 20 treatments compared to a 2-fold increase after just one. That's powerful evidence of an additive or cumulative priming effect of hyperbaric oxygen on stem cell mobilization as the total dose, in terms of number of sessions, increases. This strongly supports the need for a series of treatments for this specific effect.
It's a very clear dose response based on the total number of exposures. And Marks and colleagues' classic work on angiogenesis, the formation of new blood vessels, also provided evidence for a dose response related to the pressure used in a single session, which determines the partial pressure of oxygen.
What did Marks show?
They demonstrated that angiogenesis occurred when breathing oxygen at 2.4 atmospheres, absolute total pressure. But importantly, it did not occur while breathing room air at 1 atmosphere absolute, or even while breathing 100% oxygen at 1 atmosphere absolute.
So you need the hyperbaric pressure and the very high associated partial pressure of oxygen to drive angiogenesis in this model. You can't get it just with normobaric oxygen.
Exactly. And animal studies using irradiated rats provided even more detailed insight into this dose response for angiogenesis. They show that new blood vessel formation was directly proportional to the oxygen pressure in the hyperbaric environment.
Could you describe the shape of that dose response curve based on the source's description? What did it look like?
Sure. Picture a graph where the x-axis represents the oxygen pressure in atmospheres absolute,
Yeah.
and the axis represents a measure of blood vessels per tissue area, reflecting the degree of angiogenesis.
Got it.
The source describes the curve showing a minimal but steady increase in blood vessels as the pressure increased from 1.0 atmospheres absolute up to 2.0 atmospheres absolute, so a slow climb.
Okay.
Then, something significant happened at 2.5 atmospheres absolute. There was a sharp increase in blood vessel formation. The maximal result was observed at the highest pressure studied, 3.0 atmospheres absolute.
So it's not a simple linear increase across the entire pressure range. There seems to be a threshold or an inflection point somewhere between 2.0 and 2.5 atmospheres absolute, where the angiogenic response dramatically accelerates. That visual, a slow, steady climb, followed by a sharp, dramatic spike, is very helpful for understanding this non-linear cellular dose response to pressure for angiogenesis in irradiated tissue.
So the evidence for a dose response at the cellular or biomarker level is quite compelling. Increased proliferation, suppressed intercellular adhesion molecule expression, increased stem cell mobilization with cumulative treatments, and pressure-dependent angiogenesis with a seemingly nonlinear response at higher pressures.
Given this clear cellular dose response, you might logically expect to see a similar dose response translate directly to clinical outcomes in patients, where higher doses or longer courses lead to predictably better results. But the source asks the critical question, is there evidence for a similar clinical dose response curve? Does it hold up in patients?
And the general finding stated in the source, which we touched upon earlier, is that few studies have been conducted that directly compare treatment at 1 atmospheric pressure against another.
Not many head-to-head trials.
No. And almost all of the studies that have attempted this comparison were retrospective in nature. Many simply compared patient cohorts treated at different pressures across different time periods or facilities, which introduces the potential for significant selection bias.
Right. Were the patients treated at 2.4 atmospheres absolute truly comparable to those treated at 2.0 atmospheres absolute, or were there underlying differences that influenced their outcomes? Hard to know retrospectively.
Exactly. That lack of perspective, randomized head-to-head trials directly comparing different pressures makes drawing definitive conclusions about a clinical dose-response curve based on pressure alone very challenging. But let's look at the condition-specific evidence the source does provide, even if it's limited and observational. Diabetic foot ulcers are mentioned first.
Okay, DACU, what did they find?
Fife and colleagues conducted a study comparing two groups of patients with diabetic foot ulcers treated at 6 different hyperbaric facilities. They included 221 patients, with one group receiving treatment at 2.0 atmospheres, absolute total pressure, and the other at 2.4 atmospheres, absolute total pressure.
What did they find regarding tissue oxygenation in those groups? The source mentions transcutaneous oxygen measurements. Did higher pressure mean higher tissue oxygen?
Yes, they found that a significantly higher percentage of patients in the 2.4 atmospheres absolute group reach a transcutaneous oxygen measurement over 600 millimeters of mercury, compared to the 2.0 atmospheres, absolute group of 75% versus 32.8%.
Okay, so 2.4 ATA definitely drives tissue oxygen higher. Makes sense.
Right. Transcutaneous oxygen measurements reflect the oxygen tension in the skin and subcutaneous tissue. Elevated levels like 600 millimeters of mercury indicate very high tissue oxygenation, suggesting a potentially favorable environment for healing. It's physiologically expected that breathing oxygen at a higher total pressure would more effectively drive oxygen into the tissues.
So, higher pressure clearly leads to higher tissue oxygenation, which seems like a beneficial physiological effect. But did that better tissue oxygenation translate into a difference in clinical outcomes, like wound healing or limb salvage? That's the key question.
This is where the study's findings become complex and challenge simple dose-response assumptions. When they statistically adjusted the results for potentially confounding factors, such as the initial severity of the ulcer, Wagner grade, patient age, duration of diabetes, or the total number of treatments received,
Controlling for those variables.
they found no difference in clinical outcomes between the 2.0 atmospheres absolute and 2.4 atmospheres absolute treatment groups.
No difference in outcome. That's perplexing. Higher partial pressure of oxygen delivered, leading to better tissue oxygenation as measured by transcutaneous oxygen, but no statistically significant difference in the eventual clinical outcome like wound healing.
Precisely. Their conclusion, as stated in the source, was that there may be a minimal effective dose of oxygen required for the treatment of diabetic foot ulcers.
A minimal effective dose, meaning once you hit a certain threshold, more isn't better.
That's the idea. Once you reach a certain threshold level of tissue oxygenation, perhaps measured by transcutaneous oxygen, simply increasing the pressure further to achieve even higher levels might not provide additional clinical benefit in terms of wound healing outcomes within the context of their study.
This finding poses a crucial question for us as clinicians, doesn't it? If a higher dose, by pressure, achieves better tissue oxygenation but doesn't lead to better clinical outcome, what does that suggest about the dose response? Is there a plateau effect at the clinical level? Or are other factors like overall wound care, patient comorbidities, or mechanical offloading becoming the primary determinants of healing once a sufficient level of oxygenation is achieved?
Those are exactly the right questions.
This could definitely be framed as a board question. Discuss the findings of Fife et al., comparing hyperbaric oxygen at 2.0 versus 2.4 atmospheres, absolute for diabetic foot ulcers, focusing on the relationship between treatment pressure, transcutaneous oxygen levels, and clinical outcomes. Interpret the concept of a minimal effective dose in light of their data.
Absolutely. That finding is a great example of where the clinical data doesn't perfectly align with expected physiological benefits.
What about the Hyperbaric study on diabetic foot ulcers? They took a different approach, right? Trying to individualize treatment pressure based on oxygenation response.
Yes, Hayward and colleagues applied the concept of individualizing the treatment pressure needed for each patient to reach a target transcutaneous oxygen measurement of 250 millimeters of mercury while breathing hyperbaric oxygen. This is a different target level than the 600 millimeter Hg measured in the Fife study, but still represents a physiological goal for tissue oxygenation thought to be conducive to healing.
So they adjusted the pressure during treatment until the patient achieved that specific transcutaneous oxygen target, titrating to effect almost.
Their method involved testing patients at 2.0 atmospheres absolute, and if they didn't reach the target transcutaneous oxygen there, they would attempt treatment at 2.4 atmospheres absolute to see if the target could be reached at the higher pressure.
Okay. And could more patients reach the target at the higher pressure?
Yes. Out of 142 patients, 79.3% were able to reach the 250 millimeters of mercury transcutaneous oxygen target using 2.0 atmospheres absolute. As might be expected, a higher percentage, 86.6%, were able to reach the target using 2.4 atmospheres absolute. Again, makes physiological sense, higher delivered pressure, more likely to drive tissue oxygenation to the target level.
Okay, so 2.4 atmospheres absolute was more effective at getting patients to that tissue oxygenation target. What about the actual wound healing rates in this study? Did hitting the target correlate with healing?
This is where Habor's findings become even more complex and, frankly, seemingly paradoxical when viewed in isolation. Among the patients treated at 2.0 atmospheres absolute, if they did reach the target transcutaneous oxygen of greater than 250 millimeters of mercury during treatment, their healing rate was 70.6%.
Okay, 70% healing if they hit the target at 2.0 ATA.
If they didn't reach the target at 2.0 ATA, the healing rate was only 11.8%. That difference is statistically significant, showing a strong association between achieving that tissue oxygenation goal and clinical healing at that specific pressure.
That strong association between hitting the oxygenation target and healing within the 2.0 atmospheres absolute group makes intuitive clinical sense. Hit the physiological goal, get the outcome.
Now, look at the 2.4 atmospheres absolute group. If those patients did reach the target, transcutaneous oxygen of greater than 250 millimeters of mercury at 2.4 atmospheres absolute, their healing rate was 33.3%.
Only 33%. That's much lower than the 70% at 2.0 ATA, even though they hit the same target.
Exactly. If they didn't reach it at 2.4 atmospheres absolute, the healing rate was 14.3%. Again, a significant difference linking achieving the target to healing within that specific pressure group.
Okay, so within each pressure group, if you hit the oxygenation target, healing is significantly better than if you don't. That holds true. But here's the confusing part. The healing rate when the target was reached at 2.4 atmospheres absolute, 33.3%, was significantly lower than the healing rate when the target was reached at 2.0 atmospheres absolute, 70.6%. That seems completely contradictory to a simple dose-response assumption where more pressure, leading to a higher chance of hitting the oxygenation target, should translate to better healing outcomes, especially when the target was successfully achieved.
It is a very puzzling finding, and the source doesn't provide a definitive explanation. Why would patients who successfully achieve the 250 millimeter mercury tissue oxygenation target at the higher pressure, 2.4 atmospheres absolute, heal at a lower rate than those who achieve the exact same target at the lower pressure, 2.0 atmospheres absolute?
Yeah, what could explain that?
This result strongly suggests that something beyond just hitting that specific partial pressure of oxygen target is influencing the clinical outcome, or that there might be significant selection bias at play in a non-randomized study,
Ah, selection bias again.
where patients were essentially self-selected into the 2.4 atmospheres absolute group if they failed to meet the target at 2.0 atmospheres absolute. Perhaps patients who required 2.4 atmospheres absolute to reach the target were inherently sicker, with more complex underlying issues that limited their healing potential despite achieving the physiological oxygenation goal.
That finding from Haber and colleagues is a great example of the complexities and apparent contradictions you encounter in real-world clinical data, making it difficult to draw simple conclusions about dose response based on pressure alone. It underscores the need for caution and critical interpretation of observational data. Let's look at carbon monoxide poisoning. The source mentions a prospective, randomized trial in this area, which generally provides stronger evidence than retrospective studies.
Yes, Hampson and colleagues conducted a prospective, randomized trial involving 30 patients with carbon monoxide poisoning. They directly compared treating patients with hyperbaric oxygen at 2.4 atmospheres, absolute total pressure, versus treating them at a higher pressure, 3.0 atmospheres, absolute total pressure.
So, a direct randomized comparison of a common treatment pressure versus an even higher one. What did they find regarding clinical outcomes? Did 3.0 ATA work better?
They assessed neuropsychiatric testing results immediately after the hyperbaric oxygen treatment course, and again 14 to 21 days later. They found no statistically significant differences in these neuropsychiatric outcomes between the group treated at 2.4 atmospheres absolute and the group treated at 3.0 atmospheres absolute.
No difference. That's a significant finding from a randomized trial, despite the relatively small sample size. It suggests that for neuropsychiatric recovery following carbon monoxide poisoning, increasing the pressure from 2.4 to 3.0 atmospheres absolute doesn't seem to offer additional benefit within this time frame, even though higher pressures would theoretically drive faster carbon monoxide elimination. This might indicate that 2.4 atmospheres absolute is sufficient, or perhaps that the speed of carbon monoxide clearance beyond what 2.4 atmospheres absolute provides isn't the primary limiting factor for neuropsychiatric outcome in the intermediate term.
It's another piece of clinical evidence suggesting a lack of a clear clinical dose response above a certain pressure threshold, even if cellular effects like angiogenesis might continue to increase with pressure in other tissues.
What about late radiation tissue injury? The source discusses studies on both mandibular osteoradionecrosis and radiation cystitis. Let's start with the jaw, ORN.
For mandibular osteoradionecrosis, a retrospective study by Heitman and colleagues involving 38 patients compared outcomes for those treated at 2.0 atmospheres absolute versus those treated at 2.4 atmospheres absolute. They found no difference in the ability of hyperbaric oxygen to prevent mandibular osteoradionecrosis in this cohort based on the treatment pressure used.
So similar to the DFU and carbon monoxide findings, no clinical difference observed between 2.0 and 2.4 atmospheres absolute for preventing this specific type of radiation injury in this retrospective study.
Okay. What about the bladder, radiation cystitis?
Similarly, for radiation cystitis, Ajayi and colleagues conducted a study comparing outcomes for patients treated at 2.0 atmospheres absolute versus 2.4 atmospheres absolute. They also showed no difference in clinical response between the two pressure groups.
Again, no clinical difference in outcome observed between 2.0 and 2.4 atmospheres absolute for late radiation tissue injury, specifically radiation cystitis.
Yeah.
Was there any other notable difference in the radiation cystitis study findings, even if the clinical outcome was the same? Anything else pop up?
Yes, there was a potentially important difference noted, although the study compared groups from two different institutions. They found that patients treated at 2.0 atmospheres absolute required an average of 5.5 more treatments than those treated at 2.4 atmospheres absolute to achieve the same clinical response. Ah, So while the final clinical outcome was similar, the efficiency in terms of the number of treatments required might have been different. Achieving the same result potentially took more sessions at the lower pressure in this study.
Exactly. This finding suggests that even if the clinical endpoint is eventually reached at either pressure for radiation cystitis, choosing the lower pressure might necessitate a significantly longer course of treatment. That has real-world implications for patient time commitment, facility throughput, and healthcare costs.
Definitely. But the source adds a crucial caveat here. This comparison was made between groups from two different institutions.
Yes, that's critical. Therefore, potential differences in patient populations, referral patterns, or other treatment practices between the facilities that could introduce selection bias cannot be excluded and might explain the difference in treatment numbers.
That potential for selection bias is critical to consider when interpreting retrospective data comparing groups from different sites. But if we consider the finding for a moment, it implies that while the clinical outcome might be equivalent for late radiation tissue injury, like radiation cystitis, between 2.0 and 2.4 atmospheres absolute, the lower pressure might require a longer course, which impacts operational efficiency and resource utilization.
It certainly highlights how operational considerations can become intertwined with apparent clinical findings, especially when definitive randomized comparisons are lacking.
So, to summarize this discussion on dose response, we have clear, strong evidence of a dose response at the cellular and biomarker level. Processes like cell proliferation, intercellular adhesion molecule suppression, stem cell mobilization, and angiogenesis all show a response that is proportional to oxygen pressure or cumulative exposure.
Right, with some evidence of nonlinear effects at higher pressures for angiogenesis and cumulative effects for stem cell mobilization, the cell biology seems pretty clear.
However, translating this clear cellular dose response into a consistent, demonstrable clinical dose response curve has proven challenging. The available clinical evidence is limited, often retrospective, and sometimes contradictory.
Exactly. For diabetic foot ulcers, studies suggest a minimal effective dose based on tissue oxygenation might exist. But the link between higher pressure, tissue oxygenation, and clinical outcome is complex and potentially influenced by bias, as seen in the Haber data showing puzzling differences in healing rates between pressures when the oxygenation target was met.
For carbon monoxide poisoning, a randomized trial found no difference in neuropsychiatric outcome between 2.4 and 3.0 atmospheres absolute.
And for late radiation tissue injury, studies typically show no clinical outcome difference between pressures like 2.0 and 2.4 atmospheres absolute, although one study hinted at needing more sessions for radiation cystitis at the lower pressure, a finding potentially influenced by selection bias due to comparing different institutions.
This inconsistent clinical picture, combined with the lack of definitive head-to-head trials comparing different pressures, means that in clinical practice, decisions about choosing between pressures like 2.0 and 2.4 atmospheres absolute often have to balance the potential but unproven benefit of a higher dose against the known risk of oxygen toxicity at higher pressures.
Relying heavily on available historical evidence and consensus rather than clear comparative data.
And as we've seen throughout this deep dive, operational considerations continue to play a significant role in influencing the choice of pressure. As the source points out, in monoplace chambers with longer air washout times during compression, using a slightly higher pressure, like 2.4 atmospheres absolute, might be favored, similar to Davis's historical reasoning, simply to help guarantee that a minimum effective partial pressure of oxygen is actually delivered to the patient despite initial air dilution.
Conversely, in multiplace chambers, using higher pressures like 2.4 atmospheres absolute increases the risk of decompression sickness for the inside attendants who are breathing air.
Right, the staff risk.
This practical concern for staff safety might necessitate using lower treatment pressures for the patient or implementing specific risk mitigation protocols for the attendants, such as having them breathe oxygen before chamber decompression. So the desired patient dose and pressure can involve a direct trade-off with staff safety and operational constraints in a multi-place environment.
This entire discussion on dose response highlights the disconnect between the relatively clear cellular level effects and the much less clear clinical outcome data, demonstrating why operational factors often influence protocol decisions in the absence of robust comparative dose-finding studies at the clinical level. That provides a comprehensive recap for Section 5.
Okay, moving on to the next major component of hyperbaric oxygen dosage, treatment frequency. How often should treatments be given over time?
The source states that the most common frequency for hyperbaric oxygen administration is daily treatment, once a day.
Yes, typically this means once per day, often scheduled on weekdays, allowing for a break on weekends. However, there are specific exceptions for acute, severe, time-sensitive indications.
Like gas gangrene or neck fast.
Exactly, gas gangrene or necrotizing soft tissue infections. For these critical conditions, some protocols recommend more frequent treatments, such as twice daily or even 3 times daily, particularly in the initial phases of treatment.
For those indications requiring more frequent treatments, the source mentions a real-world challenge with achieving ideal timing. Getting them in BD or TID isn't always easy.
Right. While ideally, twice-daily treatments would be spaced approximately 12 hours apart to distribute the oxygen exposure and its effects as evenly as possible over a 24-hour period, operational limitations in a busy clinical facility often make this difficult.
I can imagine.
Scheduling pressures might necessitate spacing treatments closer together, sometimes only 6 hours apart, for example. This leads to a biologically asymmetrical delivery of oxygen and its stimulus over the course of the day, which might or might not impact the overall clinical effectiveness compared to ideally spaced treatments. We just don't know for sure.
That makes perfect sense from a scheduling perspective, but it's not ideal if the biological effect requires a certain duration or spacing for optimal stimulation. It seems like understanding the optimal treatment frequency requires a better understanding of how long the beneficial effects of a single dose of oxygen actually persist in the body after the treatment session is completed.
Exactly. This is where a common question arises from both patients and physicians who are new to hyperbaric oxygen therapy. Why is spending just 1 or 2 hours in the hyperbaric chamber receiving oxygen once a day sufficient when the patient is breathing normal air and is at normal atmospheric pressure for the other 22 or 23 hours of the day? How can such a short, intermittent exposure possibly be enough to treat a chronic condition?
It's a very logical question that addresses the apparent discontinuity of the treatment. Seems like too little, too spread out.
And the source clarifies that the rationale behind daily dosing, despite the long interval between treatments, is often misunderstood. If the only physiological problem being addressed were pure, simple hypoxia, such as from acute severe blood loss anemia, where the body simply lacks enough oxygen carriers,
Right, just low oxygen content.
then yes, the therapeutic strategy would logically be to keep the patient in the hyperbaric environment as continuously as possible to maintain high tissue oxygen levels around the clock.
Like keeping someone on continuous high-flow oxygen or even using mechanical ventilation with high oxygen if they were just acutely hypoxic at sea level. Makes sense.
Precisely. However, the source notes that pure hypoxia is rarely the sole or primary issue being treated with hyperbaric oxygen. For conditions like ischemic flaps, where the tissue blood supply is critically compromised, the tissue viability is extremely oxygen sensitive. In these cases, protocols do often require multiple treatments initially, sometimes every 6 or 8 hours in the first 24 to 48 hours, in an attempt to maximize oxygen delivery and salvage the tissue during that acute critical window.
Okay, so for those acute limb-threatening or tissue-threatening situations, more frequent treatment up front makes biological sense to provide continuous oxygen support. Get as much oxygen in as possible.
Yes, but typically, once that initial acute phase requiring near-continuous oxygen support is stabilized, standard protocols often transition to daily administration.
Oh.
And the reason daily dosing is thought to be sufficient for many conditions is because accumulating evidence shows that many of the pharmacological effects initiated by hyperbaric oxygen exposure persist for many hours and even days after the patient leaves the chamber.
So the benefit isn't limited to just the time they are physically breathing oxygen under pressure. It lasts longer.
Exactly. The treatment acts as a trigger that sets off beneficial processes that continue long after the session is over.
Okay, what are some specific examples of these persistent effects highlighted in the source? Things that last.
The source provides several examples. The inhibition of beta-2 integrin-dependent neutrophil adhesion.
Okay, that inflammatory cascade component.
Yes. That's been shown to last up to 20 hours post-hyperbaric oxygen exposure. Beta-2 integrins are cell surface proteins on immune cells, like neutrophils, that are essential for them to stick to the walls of blood vessels and migrate into injured tissues.
Right.
Inhibiting this process can reduce the accumulation of these inflammatory cells at sites of injury, potentially reducing tissue damage and promoting healing, particularly in conditions involving ischemia-reperfusion injury.
So, a single hyperbaric oxygen treatment can help dampen excessive inflammation for most of the day afterwards. That's a significant carryover effect.
Yes. Another example is serum erythropoietin levels.
Hmm.
As we mentioned earlier, erythropoietin unexpectedly dropped after normobaric oxygen breathing, but following hyperbaric oxygen, serum erythropoietin levels were followed by a significant increase that was observed at both 24 and even 36 hours post-treatment.
A physiological effect that actually increases and is still elevated more than a day after the treatment session ends. That's a clear example of a delayed and prolonged response, very different from just giving oxygen.
Exactly. And fibroblast activity, which is absolutely crucial for producing the extracellular matrix and collagen needed for wound healing and tissue remodeling, also showed a delayed and prolonged response.
What happened with fibroblasts?
After a single 120-minute exposure to hyperbaric oxygen, fibroblast activity actually increased at 24 hours post-treatment and continued to increase at 47 and 72 hours.
3 full days after a single treatment session, the fibroblasts are still showing increased activity compared to baseline. That's remarkable evidence of a sustained stimulus. Picture the hyperbaric oxygen as a powerful but delayed release signal that doesn't just work while it's being delivered, but triggers a cascade of biological events that continue to unfold over the following days.
It truly is, and these prolonged biological effects are the very basis for the concept of hyperbaric oxygen preconditioning.
Treating before an injury.
Yes, where a series of treatments is given before an anticipated injury, such as surgery or radiation therapy. The underlying assumption is that the beneficial physiological effects initiated by those treatments will persist and be active in the tissues when the injury eventually occurs, helping to mitigate its severity.
These documented persistent effects lasting for hours and days really underline why daily dosing, despite the long intervals between treatments compared to the treatment duration itself, might be physiologically sound and sufficient for many conditions. And the source highlights the discovery of hypoxia-inducible factor, HIF, as significantly increasing our understanding of the molecular basis for this persistence.
Yes, the source specifically emphasizes that the discovery of HIF and the pathways it regulates has helped researchers understand why some effects of hyperbaric oxygen can last for days and provides a compelling theoretical basis for the sufficiency of daily rather than more frequent hyperbaric oxygen administration for many indications.
Tell us more about this hypoxia-inducible factor hypothesis, particularly what the source refers to as the relative hypoxia theory. This sounds important.
Okay. As we briefly discussed, under normal oxygen conditions, normoxia, HIF protein, specifically HIF-1 alpha, is rapidly synthesized and then quickly broken down.
Right. It disappears quickly normally.
It's only under conditions of true tissue hypoxia, dangerously low oxygen levels, that HIF is stabilized and can then enter the cell nucleus to act as a transcription factor, binding to specific DNA sequences and activating the expression of genes that are essential for the cell or tissue to survive and adapt to that low oxygen environment. These include genes that promote angiogenesis, glucose transport, and the production of growth factors.
So in a truly hypoxic wound or ischemic tissue, HIF-1 alpha stabilizes to try and activate repair and survival genes to help the tissue cope with the lack of oxygen. Basic survival mechanism.
Right, now here is the fascinating hypothesis put forward, which the source calls the relative hypoxia theory. It proposes that the dramatic transition the tissue experiences from the state of extreme hyperoxia, very high partial pressure of oxygen, inside the chamber, to the standard normoxic state, normal partial pressure of oxygen, outside the chamber.
That big drop when you come out.
Yes, where tissue oxygen levels drop precipitously back towards normal baseline, actually creates a relative hypoxia compared to the supersaturated state the cells were just in.
So the tissue isn't necessarily truly hypoxic in an absolute sense once the patient is outside the chamber, but it feels low in oxygen relative to the incredibly high levels it just experienced. Is that the idea?
Precisely. And this significant relative decrease in oxygen tension from the hyperoxic peak back down to normoxia is theorized to be the stimulus that effectively stabilizes HIF. Even though the tissue might now technically be normoxic, the rapid and large drop in oxygen levels acts as a signal, preventing the usual rapid breakdown of HIF. This stabilized HIF can then proceed to activate the transcription of those beneficial genes, the ones for growth factors, angiogenesis factors, matrix production enzymes, etc. Over the next few hours and days, long after the partial pressure of oxygen in the tissue has returned to baseline normoxic levels.
Okay, picture this analogy. You step out of a brightly lit operating room into a standard corridor. The corridor isn't truly dark, but it feels dark relative to the bright room you just left. And that sudden change triggers your pupils to dilate, an effect that lasts for a while even though the corridor is normally lit. Similarly, stepping out of the hyperbaric bright light into normobaric normal light creates a relative drop that triggers HIF stabilization, and that cellular pupil dilation affect the gene activation and growth factor production continues for days. Is that a fair analogy?
That's a great way to visualize it. This downstream effect of sustained gene expression and growth factor elaboration, driven by the initial hyperbaric exposure via the HIF pathway or other HIF-regulated genes, is what is believed to persist for days. This provides a powerful theoretical mechanism that helps explain why daily hyperbaric oxygen dosing, despite the long intervals between treatments, can be biologically plausible and often sufficient for driving healing and regenerative responses in many conditions.
This hypothesis is a key proposed mechanism supporting the efficacy of daily treatment intervals. A good question to solidify this understanding might be: explain the relative hypoxia theory and the proposed role of HIF-1 alpha stabilization as a mechanism for the persistence of hyperbaric oxygen's effects for days post-treatment, supporting the rationale for daily dosing.
That covers the core idea well.
That relative hypoxia concept linked to HIF is a critical insight from the source regarding treatment frequency. So, to quickly recap Section 6, daily treatment is the standard frequency, with exceptions for acute infections requiring more frequent, though often operationally limited and asymmetrical treatments.
Right.
The surprising sufficiency of daily dosing, despite the patient being normobaric and normoxic for most of the day, is supported by evidence showing that the pharmacological effects of hyperbaric oxygen persist for many hours and days post-treatment.
Including delayed effects on neutrophil adhesion inhibition, erythropoietin increase, and prolonged fibroblast activity.
And the fascinating relative hypoxia hypothesis, proposing that the rapid transition from hyperoxia to normoxia stabilizes HIF to drive sustained beneficial gene expression, provides a key theoretical mechanism for these sustained effects that justify a daily treatment frequency for many indications.
And that brings us to the final major component of hyperbaric oxygen dosage we'll explore based on the source: treatment length, which refers to the total number of treatments prescribed in a complete course.
While a single hyperbaric oxygen treatment clearly has documented physiological effects, as we've discussed, like short-term changes in tissue oxygen or immediate cellular responses, those happen right away.
Yes, but the source points out that while a single treatment can have acute effects, most conditions treated with hyperbaric oxygen, with the clear exception of acute single-event issues like decompression sickness or acute carbon monoxide poisoning, rely on the cumulative impact of a series of treatments to achieve a sustained clinical outcome. You need more than one.
And what is the commonly used length of these treatment courses for chronic conditions? What's the standard number?
Commonly used protocols, especially for chronic issues like wound healing, radiation injury, or osteomyelitis, typically recommend a course of 30 or more treatments, usually administered on a daily basis, as we discussed.
30 or more. Okay. Is that number well supported by evidence?
Well, the source adds a crucial point of nuance. Very few studies have rigorously tested this specific number of 30 or more treatments. Yes, this means that while 30-plus sessions is common practice, that specific number is often based more on historical precedent, consensus, or extrapolation from earlier studies, rather than robust comparative trials, specifically designed to determine the optimal total number of treatments for every indication.
So, the common benchmark of 30 or 40 sessions isn't necessarily proven to be the optimal number for every condition. It's more of a historical standard.
In many cases, yes. But is there evidence that a longer course, a series of treatments, does provide an additive or cumulative benefit compared to just one or a few sessions?
Does it? What does the data show?
Yes, absolutely. There is strong evidence for an additive or cumulative effect with additional hyperbaric oxygen treatments, particularly when looking at cellular or biomarker responses. We already highlighted stem cell mobilization as a key example.
Right, the twofold versus eightfold increase.
Exactly. Circulating stem cells increase by about twofold after a single treatment. But remarkably, after a series of 20 treatments, that mobilization increases to an eightfold increase compared to baseline. That is a dramatic cumulative effect based on the total number of exposures.
That eightfold increase after 20 sessions is a powerful illustration of how repeated treatments can significantly amplify a biological response compared to a single session. This strongly supports the need for a series of treatments for this specific effect. What about angiogenesis, the formation of new blood vessels, which we saw as dose-dependent on pressure in a single session? Does that accumulate too?
Marks and colleagues also studied angiogenesis in irradiated tissue over the course of multiple hyperbaric oxygen treatments. They measured capillary density using transcutaneous oxygen measurements, which correlate with the density of blood vessels in the tissue.
Okay.
Their work showed that capillary density increased from a baseline of around 30% in the damaged irradiated tissue before hyperbaric oxygen therapy to a much higher level, around 80%, after approximately 20 treatments.
So, multiple treatments are clearly needed to drive significant formation of new blood vessels in compromised tissue. It takes time and repetition.
Right. And importantly, the source notes that this improvement in capillary density in angiogenesis plateaued at that approximately 80% level and remained at this level for 3 years post-hyperbaric oxygen therapy.
A plateau effect, again, similar to what we might infer from the clinical outcome data for diabetic foot ulcers at higher pressures. That suggests there may be a point of diminishing returns for additional treatments once a certain level of vascularization is achieved in irradiated tissue. Giving more treatments beyond that plateau might not provide further benefit for angiogenesis in that specific tissue type. Is that right?
That seems to be the implication. This plateau concept is important when considering total treatment length. Marx's proposed protocol of 30 preoperative and 10 postoperative treatments for mandibular osteorating necrosis, totaling 40 sessions, was likely developed based on observations like this, aiming to achieve maximal tissue preparation for surgical repair in radiation-damaged bone.
So that's where the 30-40 number comes from, partly.
Yes. The source notes that this range of 30 to 40 treatments has subsequently been carried forward and adopted as a generalized starting point or benchmark for many other indications, even without specific evidence demonstrating that this exact number of treatments is optimal for those diverse conditions.
So it's a clear example of how historical practice, often based on findings for one specific condition, influences current standard protocols for many others, highlighting the lack of indication-specific dose-finding studies for total treatment length.
According to the source, yes, that historical influence is significant. However, there is some clinical data linking total treatment length to outcome for specific conditions. The source revisits radiation cystitis, a type of late radiation tissue injury.
Right, the bladder again.
Where patients who received longer courses of hyperbaric oxygen generally had better outcomes. Specifically, the best results were observed in patients who received over 100 atmosphere hours of total oxygen exposure and completed 40 treatment days.
Okay, this finding for radiation cystitis directly links total cumulative exposure, quantified potentially by the oxygen hours concept we discussed, partial pressure multiplied by time multiplied by sessions, and the total number of sessions, 40 days, to achieving the best clinical outcome for this specific condition.
It does.
This provides some clinical support for the importance of both cumulative dose and total treatment length, and lends some clinical relevance to the oxygen hours concept, albeit from observational data mentioned earlier.
Exactly. For radiation cystitis, it appears total cumulative exposure over a significant number of sessions is key. However, the source also provides examples where shorter courses of hyperbaric oxygen have shown benefit or no significant difference compared to longer courses or shams.
Like inflammatory bowel disease.
Yes, a study by Dulai and colleagues on inflammatory bowel disease showed that 5 sessions of hyperbaric oxygen resulted in superior outcomes compared to just 3 sessions.
Okay, so more is better than very few, but maybe not 30 needed.
Right. This suggests that for this condition, there may be a minimum threshold of treatments needed to see a clinical effect. More than 3, but perhaps less than the standard 30 plus. But doesn't necessarily imply that the longer courses are required or optimally effective.
What about carbon monoxide poisoning again? The source mentions Weaver's work again, with findings that seem conflicting regarding the optimal number of early treatments. This came up before.
Yes. Weaver's earlier work, as cited, demonstrated that administering 3 hyperbaric oxygen treatments within 24 hours of carbon monoxide poisoning reduced the incidence of delayed neurological symptoms from 46.1% in the sham group to 25.0%.
Okay, so 3 treatments compared to sham showed a benefit for preventing delayed neurological symptoms. That sounds good.
Yes, this finding supports the idea that receiving multiple treatments early on is beneficial for this specific outcome. But then, the source states that Weaver subsequently showed no difference in the incidence of delayed neurological symptoms when comparing patients who received 1 treatment versus those who received 3 treatments.
Wait, no difference between 1 and 3? But 3 was better than sham. That is a direct contradiction within the source's presentation of Weaver's work.
It is.
The first finding suggests that getting 3 treatments is beneficial compared to sham, implying that one treatment might not be enough. But the later finding says there's no difference in outcome between receiving one treatment versus 3 treatments. This ambiguity makes it difficult to draw a firm conclusion from the source about the optimal number of early treatments for preventing delayed neurological symptoms in carbon monoxide poisoning. Does one treatment provide the maximal benefit, or is there something else at play? This is a point of confusion in the evidence presented.
It is confusing, a direct conflict between two findings attributed to the same researcher. And then Lee and colleagues' study on carbon monoxide poisoning added another piece to this conflicting picture.
What did Lee find?
Lee and colleagues conducted a study on carbon monoxide poisoning and found no difference in overall outcomes when patients received more than one hyperbaric oxygen treatment in the first 24 hours post-poisoning compared to those who received only one treatment.
Okay, so Lee's study supports the one might be enough idea, contradicting Weaver's first finding.
It seems to. This finding directly contradicts the idea suggested by Weaver's initial finding, 3 versus sham reducing delayed neurological symptoms, that multiple treatments within 24 hours are beneficial for carbon monoxide poisoning outcomes in general, at least in terms of overall outcomes, not specifically just delayed neurological symptoms. It adds to the conflicting evidence regarding the optimal early treatment frequency and total number of initial treatments for this indication.
So even for this acute, well-studied indication like carbon monoxide poisoning, the optimal number of initial treatments is debated, and the published evidence, as presented in the source, contains conflicting findings.
Wow. It highlights how challenging it can be to establish clear, definitive dosing guidelines, even for established indications. Now, shifting to a very practical question that comes up frequently in clinical practice. Do missed treatments during a course adversely affect the overall clinical response?
This is a common concern for both patients and clinicians. Standard hyperbaric oxygen protocols often run daily on weekdays, inherently including weekend breaks, meaning patients miss 2 days a week compared to a theoretically continuous course. But patients might also miss treatments due to illness, transportation issues, or other personal reasons. What happens then?
The source provides data on this practical issue, drawing from studies on late radiation tissue injury outcomes by Hampson and Corman, specifically looking at radiation cystitis and proctitis.
Okay, what did they find about missed treatments for LRTI?
They analyzed whether the frequency of treatments per week impacted the outcome. They found no difference in outcome for patients who had 5 or fewer treatments per week compared to those who had more than 5 treatments per week. They also looked at a wider range and found no difference between those receiving 3 or fewer treatments per week versus those receiving 7 or more treatments per week.
This is a significant and clinically reassuring finding. It suggests that for late radiation tissue injury, the strict weekly frequency of treatments within a certain range, at least 3 per week, might not be critical for achieving a positive clinical outcome. This provides some support and reassurance for facilities operating 5 days a week and for patients who occasionally miss a treatment during their course for radiation cystitis or proctitis.
However, and this is a crucial distinction from the same study on late radiation tissue injury, while weekly frequency didn't seem to matter much within a range, the total number of treatments received was strongly associated with outcome.
The total number again?
Yes. Patients who received less than 30 total treatments during their course had a 58% response rate, while those who received 30 or more total treatments had a significantly higher 80% response rate.
That's a major difference in clinical response based on total treatment length. So for late radiation tissue injury, like radiation cystitis or proctitis, the total number of treatments received, specifically reaching that threshold of 30 or more sessions, seems much, much more important for achieving a positive outcome than the strict weekly frequency of those treatments, at least within the ranges studied. Frame this as a key clinical takeaway. For late radiation tissue injury, is weekly frequency or total number of treatments more strongly associated with positive clinical outcome? Discuss the findings from Hampson and Corman and their implications for patient management and protocol design.
Absolutely. This finding is a critical piece of evidence for managing patients with late radiation tissue injury and setting appropriate expectations regarding treatment commitment and protocol design. Now let's contrast that finding with the data presented for diabetic foot ulcers, which seems to suggest that DFU outcomes are more sensitive to interruptions in treatment.
Okay, so for DFUs,
Fife and colleagues, in their study on diabetic foot ulcers, found that patients who had an interrupted course, defined as receiving less than 3 treatments per week for 2 or more consecutive weeks, or missing 5 treatments in a row at any point, had a lower healing rate of 62.7% compared to a 75.7% healing rate for those who completed their treatment course without significant interruption.
Lower healing rate with interruptions. Okay.
Not only was the healing rate lower in the interrupted group, they also required, on average, 9 more treatments to achieve healing compared to the patients who completed their course without significant interruptions.
So for diabetic foot ulcers, interruptions in the treatment schedule seem detrimental to both the likelihood of achieving healing and the efficiency of the treatment course, requiring more sessions overall. This contrasts sharply with the findings for late radiation tissue injury, where weekly frequency seemed less critical than total sessions.
Yes. And Ennis and colleagues reinforced this finding regarding the importance of treatment completion for diabetic foot ulcers across a very large data set of over 5,000 DFU patients treated with hyperbaric oxygen.
5,000 patients. What did they find?
They found that patients who had an incomplete course, defined as receiving only about 57% of their prescribed treatments, had a significantly lower healing rate of 47.44% compared to patients with a complete course, receiving about 89% of their prescribed treatments, who had a much higher healing rate of 75.24%.
That's compelling data from a very large registry analysis. It strongly suggests that for diabetic foot ulcers, completing the prescribed course of hyperbaric oxygen is significantly associated with a higher likelihood of wound healing. Don't miss treatments if you have a DFU.
It seems that way. Finally, the source mentions the Santema randomized controlled trial for diabetic foot ulcers, using an intention-to-treat analysis.
Analyzing everyone is randomized.
Yes, which analyzes all patients according to the group they were initially assigned to, regardless of whether they actually completed the treatment. This study showed no difference in complete wound healing or limb salvage between the hyperbaric oxygen group and the control group.
No difference in the intention to treat. That sounds negative for HBO.
But the source highlights a critical detail. 35% of the patients in a hyperbaric oxygen group in that trial did not complete the full prescribed protocol.
A significant dropout rate in the group receiving the active treatment. That complicates things.
It does. When the researchers performed a per-protocol analysis, meaning they only analyzed the patients who actually completed at least 30 sessions of hyperbaric oxygen, as prescribed by the protocol, they did show a reduction in major amputation compared to the control group.
This finding highlights the significant challenge of interpreting randomized controlled trials when there's poor adherence to the protocol in the active treatment arm. The intention to treat analysis, which reflects a more real-world scenario, including non-adherence, and is often considered the most robust analysis for determining effectiveness in a general population, showed no benefit.
Correct.
But the per-protocol analysis, which only includes the patients who actually receive something closer to the intended full dose, did suggest a benefit in terms of limb salvage. Which analysis do you trust?
And this leads to an important cautionary note, highlighted by the source, regarding the interpretation of the Fife, Ennis, and Santema per-protocol analyses. They may be subject to selection bias.
What does that potential selection bias mean in this context for interpreting these findings? How could it affect the results?
It means there's a possibility that the patients who were more likely to complete a long course of hyperbaric oxygen treatment, who were more compliant, attended all their sessions, didn't have significant interruptions, might also be the same patients who were inherently more likely to have a positive clinical outcome, regardless of the hyperbaric oxygen itself.
Maybe they were just better patients overall.
Perhaps they were healthier overall, had better access to care, were more motivated and adherent with their other aspects of wound care, or had less severe underlying disease. It's difficult to definitively separate whether the completion of the treatment was the direct cause of the better outcome, or if other underlying patient factors that predisposed them to a better outcome also made them more likely to successfully complete the hyperbaric oxygen treatment course.
That potential for selection bias is a crucial point for critical thinking when looking at observational data or per-protocol analyses where adherence is linked to outcome. We can't be certain of causality. Correlation isn't causation.
It requires careful interpretation and acknowledging the limitations. However, drawing practical clinical guidance from this data, the source synthesizes the findings on missed treatments. For late radiation tissue injury, patients appear to tolerate some missed treatments, and the total number of treatments received, aiming for 30 or more sessions, seems to be more important for achieving a positive outcome than strict weekly frequency, suggesting some flexibility in scheduling is possible within a range.
That's reassuring guidance for managing occasional scheduling challenges with late radiation tissue injury patients. A missed day here or there probably isn't the end of the world if they get the total number in.
However, for diabetic foot ulcers, interrupted courses appear to be associated with worse healing rates and a need for a greater total number of treatments to achieve healing.
So, while an occasional missed session is likely not disastrous for any patient, those with diabetic foot ulcers should be particularly encouraged and supported to attend as many treatments as possible to complete their prescribed course. Consistency matters more for them, it seems.
Exactly. The source doesn't interpret the late radiation tissue injury data as permission to intentionally prescribe only 3 days a week, but rather as reassurance that occasional missed treatments are likely tolerated without jeopardizing the outcome if the total number of sessions is reached.
Got it.
And for all patients, the source emphasizes the positive association observed between completing a prescribed course of hyperbaric oxygen and achieving a positive clinical response. So patients should be strongly encouraged to maximize their attendance while keeping in mind the potential for selection bias in some of the analyses that support this association, particularly for diabetic foot ulcers.
That's a pragmatic approach based on synthesizing the available, sometimes complex and conflicting evidence regarding treatment frequency and length. To recap Section 7, most conditions require a series of treatments, with additive effects shown at the cellular biomarker level for stem cell mobilization and angiogenesis, though angiogenesis can plateau.
Right.
The common 30-40 session length benchmark is significantly influenced by historical practice for radiation injury, not necessarily proven optimal for all indications. Clinical evidence for total treatment length is mixed. Radiation cystitis outcomes seemed better with longer courses, 100 oxygen hours in 40 days, while evidence for shorter courses in carbon monoxide poisoning and inflammatory bowel disease is conflicting or suggests a lower minimum threshold might be sufficient.
And crucially, the data on missed treatments suggests that for late radiation tissue injury, the total number of treatments aiming for 30 sessions is more important than strict weekly frequency, while for diabetic foot ulcers, outcomes appear sensitive to interruptions in the treatment schedule, highlighting the potential role of selection bias in analyses linking treatment completion to success.
That brings us through the core components of hyperbaric oxygen dosing definition: factors, duration, categories, dose response, frequency, and total length based on the detailed information provided in this source material.
Okay, let's bring it all together now with a comprehensive mega recap of everything we've covered in this deep dive into hyperbaric oxygen dosing.
Sounds good. Where do we start?
We began by highlighting the fundamental problem of clinical equipoise in hyperbaric oxygen therapy, that state of genuine uncertainty among clinicians about the optimal dose.
Right. Vividly illustrated by the widespread variation in protocols being used for conditions like carbon monoxide poisoning, mandibular osteoradionecrosis, radiation proctitis, and diabetic foot ulcers, with dozens of different protocols in use across facilities.
We saw that applying traditional pharmacological definitions of dose and dosage to hyperbaric oxygen is tricky, as we often lack definitive answers to fundamental questions about optimal dose response, the duration of a single treatment's effect, the ideal frequency, and the total necessary length of a treatment course.
The actual physiological dose of oxygen delivered is best described as the partial pressure of oxygen, calculated as a product of the total ambient pressure and the fraction of inspired oxygen being breathed based on Dalton's law.
But while treatments are commonly ordered simply by total pressure, assuming 100% oxygen delivery, we learned this assumption isn't always perfectly accurate in practice due to factors like air washout time during compression in monoplace chambers, potential mask leaks diluting the oxygen,
And the need for altitude adjustments, which require complex calculations based on potentially ambiguous dosing concepts and have unknown clinical impact.
We then explored the duration of a single treatment session, typically 90 to 120 minutes, noting that this duration is supported by data showing different cell types crucial for healing, like endothelial cells and fibroblasts, respond with proliferation on different timelines within that period.
And the heart studies show how operational factors like the presence of air brakes simulating multiplace chambers versus uninterrupted oxygen delivery in monoplace chambers affect peak tissue oxygen levels and the kinetics of oxygenation in different tissues. We also introduced the emerging, though not yet standard, concept of oxygen hours as a potential way to quantify total oxygen exposure per session.
We categorized the different oxygen dosing environments into 4 types: normobaric hyperoxia, increased oxygen at sea level, hyperbaric normoxia, breathing air at hyperbaric pressure, hyperoxia less than 100% oxygen at hyperbaric pressure, and traditional hyperbaric oxygen, near 100% oxygen at higher pressures.
We discussed how the verbal description of Table 1 shows the significant overlap in achievable partial pressure of oxygen across these categories. We explored associated effects like HIF activation and reactive oxygen species production at normobaric hyperoxia, the historical context of hyperbaric air, the significant clinical controversies and conflicting study results for brain injury indications in the hyperbaric hyperoxia category, including the debate around the micropressure hypothesis and the issue of marketing confusion.
And we noted that while there's a technical continuum of possibilities, the strongest body of clinical evidence supports the traditional definition of hyperbaric oxygen administered at pressures of 2.0 atmospheres absolute and higher with near 100% oxygen.
Then we delved into the dose-response question. There is clear, strong evidence for a dose response at the cellular and biomarker level: cellular proliferation, intercellular adhesion molecule suppression, stem cell mobilization, and angiogenesis all show responses proportional to oxygen pressure or cumulative exposure, with some nonlinear effects and cumulative benefits over multiple sessions. The cells respond clearly.
However, translating this to consistent clinical outcome differences has been challenging, largely due to limited, mostly retrospective, and sometimes contradictory clinical data. For diabetic foot ulcers, studies are complex, suggesting a potential minimal effective dose based on achieving sufficient tissue oxygenation, but with conflicting data on whether higher pressure translates to better clinical outcome when that target is met, potentially influenced by selection bias.
For carbon monoxide poisoning, a randomized trial found no difference in neuropsychiatric outcome between 2.4 and 3.0 atmospheres absolute.
And for late radiation tissue injury, studies generally show no clinical outcome difference between 2.0 and 2.4 atmospheres absolute, although one study hinted at a potential need for more sessions at the lower pressure for radiation cystitis, a finding that could be influenced by selection bias due to comparing different institutions. We also noted how operational factors like monoplace chamber dynamics or multiplace attendant risk often play a significant role in influencing pressure selection in the absence of definitive clinical outcome data comparing different pressures.
We discussed treatment frequency, with daily treatment being standard, and exceptions for acute infections requiring more frequent treatments, acknowledging the operational challenges that can lead to asymmetrical spacing.
We explored the surprising sufficiency of daily dosing, despite the long intervals between treatments, supported by evidence that the pharmacological effects of hyperbaric oxygen persist for many hours and even days post-treatment.
Including effects on neutrophil adhesion inhibition, delayed erythropoietin increase, and prolonged fibroblast activity. And we introduced the relative hypoxia hypothesis, proposing that the rapid transition from hyperoxia back to normoxia stabilizes HIF to drive sustained beneficial gene expression, providing a key theoretical mechanism explaining the efficacy of daily treatment frequency.
And finally, we covered treatment length or total sessions. Most conditions require a series of treatments, with additive effects clearly demonstrated for cellular responses like stem cell mobilization and angiogenesis, although the angiogenic response appears to plateau after a certain number of sessions.
We discussed how the common 30-40 session protocol is significantly influenced by historical practice and findings for radiation injury, rather than being definitively proven optimal for every single indication.
Clinical evidence for optimal total length varies. Radiation cystitis outcomes seemed better with longer courses, 100 oxygen hours in 40 days, while evidence for shorter courses in carbon monoxide poisoning and inflammatory bowel disease is conflicting, or suggests that a lower minimum threshold might be sufficient.
Crucially, we analyzed the practical implications of mistreatments based on available data, finding that for late radiation tissue injury, the total number of sessions, aiming for 30 or more, appears to be more important for achieving a positive outcome than strict weekly frequency, suggesting some tolerance for missed sessions within a range.
In contrast, for diabetic foot ulcers, outcomes seem sensitive to interruptions in the treatment schedule, with interruptions associated with lower healing rates and a need for more total treatments, although we noted the potential for selection bias in these analyses linking treatment completion to success.
It is a remarkably complex picture, filled with nuance, areas of uncertainty, conflicting data, and clear areas where more rigorous research is needed. Operational factors clearly play a significant role in shaping real-world protocols in the absence of definitive, comparative clinical outcome data across all possible dosage parameters.
Absolutely. And as the source reminds us in closing, Hyperbaric oxygen is a medical treatment that requires a prescription from a qualified physician with expertise in hyperbaric medicine, just like any other powerful therapy. It's not something to be taken lightly.
And with that prescription comes a significant responsibility. The source emphasizes that it is incumbent upon the prescribing physician to understand these unique and complex factors of hyperbaric oxygen dosing that we've discussed today, the interplay of pressure and oxygen concentration, the nuances of delivery, the importance of duration, the differences between oxygen environments, the sometimes conflicting dose-response data, the physiology of persistent effects, and the practical considerations of frequency and total length. You need to know this stuff.
Yes. Navigating these complexities requires a deep understanding of the available evidence, its limitations, and the physiological principles involved.
And for us to truly optimize dosage determination in the future, the source makes a clear call for more rigorous research. Future studies, they argue, need to emulate the robust methodology used in pharmaceutical studies.
Like real drug trials.
Exactly. Conducting large-scale comparative dosing trials designed to directly compare different pressures, durations, frequencies, and total treatment lengths for specific indications.
Until that level of definitive evidence exists to guide every decision, we are left, as the source wisely puts it, to use common sense and rational judgment in making our selections from the many available protocol options for each individual patient, based on the best understanding we have of the underlying physiology and the clinical data available, however imperfect it may sometimes appear.
Common sense and rational judgment indeed, guided by the knowledge we've unpacked today. This deep dive has truly illuminated the complexities and ongoing questions surrounding hyperbaric oxygen dosing, despite its widespread and beneficial use for many conditions.
It reveals that while we have gained significant understanding of the cellular triggers and physiological effects, the path from that understanding to predicting and prescribing the single optimal dose for every clinical scenario remains an active area of research and clinical challenge.
So what does this all mean for you, the listener, the clinician wrestling with these decisions? Given the clear cellular dose response that often plateaus, the compelling evidence that beneficial effects persist for days post-treatment via pathways like hypoxia-inducible factor, yet the lack of consistent clinical outcome differences seen when comparing different pressures for many conditions. It's the crucial importance of total sessions over weekly frequency for some conditions, contrasted with the negative impact of interruptions for others. Are we, as a field, correctly matching our clinical treatment frequency and length protocols to the underlying biological effects we're trying to achieve? Or are operational factors and the legacy of historical practice still leading the way in the absence of definitive, large-scale clinical dose-finding trials?